Well, good evening, everybody. Welcome to this meeting of the Adults in Health Scrutiny. Tonight, I would like to welcome the Cabinet Member, Councillor Roy Webb. Thank you very much for coming along, Roy, and for everyone else who's come along to present to us. We do appreciate you giving up your time and reporting to us. Thank you. So do we have any apologies?
No apologies, Chair.
We have no apologies. I do have a late item, which is the cabinet member response actually to our topic review on care homes, which I'm going to take at the very end of the meeting because we've got a very busy agenda. That response has already gone to Council Cabinet and has been discussed and noted there. We haven't been able to receive it yet back yet to this committee, so we'll look at that later on. Thank you. Do I have any declarations of interest? And I'm sure the members of the board will look through the minutes, and are we all happy to accept them as a true record of the last meeting? Yes, thank you. I thought they were very well written, actually, so we have to thank John for that. Thank you very much, John. Right, so our first item is waiting times for A&E and hospital discharge, including with references to the Florence Nightingale issue, which is obviously something that we've been looking at ever since I've been the chair of this, well, in fact, re-elected as a councillor in 2021. So I know it's a particular issue of concern to all of us, as are particularly waiting times and hospital discharge. So we have presenting that this evening Zara Jones, Kate Brown and Jane Haywood. Could I ask you, when you start to speak, to just to introduce yourselves, just say your name and what your role is, please. Thank you, just so that we know who is whom. And what also I'm going to do on this item, if it's okay, because I have looked through your PowerPoint already, thank you, which is very good. Are we going to have that on the screen, Don? We have it on the screen, or is it coming up as a presentation? Are you going to present via the PowerPoint? Is that what you're intending to do?
We can absolutely do that, but we don't have to, I suppose, if there's issues, we can just talk.
Well, the reason I asked is because what I was actually going to do, because I think each PowerPoint has got many, it's very succinct and good presentation, thank you, but I thought that each screen has quite a lot of significant points. So what I was going to do, unusually, I was going to say, we're going to look at one PowerPoint and ask you to, and then take questions on that, rather than letting you speak and taking questions at the end. Do we have? Can we see the presentation?
Yeah.
You mean questions per slide?
Yes, that's what I mean. Thank you, Councillor Patterson. I do. So, because normally we'd have you, somebody would present and then we'd all ask questions, but I just think there are a lot of interesting points on each slide, which is actually a noun that Councillor Patterson has quite rightly seen that I couldn't remember on. Thank you. Okay, thank you very much then. So over to you.
I think these are slides.
Oh, there's a report, yeah.
I'll do the mental health one.
I'll have to get that. I'll try and get it on as they speak. It's playing at the minute, if that's all.
Okay, thanks. Well, all members of the board, of course, have the presentation on their own computers, so perhaps if they could get them up there. So would you mind starting and then pausing at the end of the points relevant to the first slide. Thank you.
If I could just introduce colleagues, just so everyone knows who we are, and then if it's okay, which might help while finding the slides on the screen, I just wanted to set a bit of context and some key messages before we then sort of go through each of the slides slide by slide. So I'm Zara Jones, Executive Director of Strategy and Planning at Derby and Derbyshire ICB. And my colleague Kate.
I'm Kate Brown, Director of Joint Commissioning and Community Development for the ICB.
James.
I'm Jane Haywood. I'm the team leader for Hospital to Home Team, which is Derby City Council element of the integrated discharge team.
Okay, so thank you for inviting us here this evening. I mean, there's the very deliberate nature of having colleagues from health and social care here, as we're very much in a collaborative, really, in terms of a partnership approach to some of the challenges that we face in our urgent and emergency care system. I know there's been previous conversations here at this committee about some of those challenges we faced. I think it's quite timely to return. Obviously, we're still in the midst of winter. We've had some significant challenges to work together as a system over recent weeks. So, as I say, it's probably quite timely to come and talk to you about where we are and where we are going forward. The slides, and I say we will go through each in turn so that you can have any of the pertinent points. But I suppose key things for me, the challenges that we face clearly aren't new in terms of the things that we've been working through for a long time, but we are absolutely seeing particularly significant pressures from a supply side. So it's not necessarily the demand, although we do have real spikes in demand at times, which do cause us problems operationally that we need to work through. But actually, when we look at things like our A&E attendances and admissions into our acute hospitals, whilst those spikes do exist, that the overall medium to longer term trends are flatter. So what we're looking at is actually some of the sort of issues in terms of delay that we're seeing within our hospitals, and that's not just within our acute hospitals, also from a mental health and community perspective, and some of that flow out in terms of discharge, which obviously we'll cover off in the presentation. Particular supply side issues relate to workforce, and particularly around social care, and Jane will help us just walk through some of the particular issues there. But indeed, you know, in terms of the care home market and wider workforce concerns, and we await more details around a national workforce plan for the NHS. These are really, you know, key issues that do cause us pressures, not just over winter, clearly in the year throughout. We have through the winter seen increasing acuity in terms of how ill people are and the complexity of some of their conditions, which also has shown itself in the data in terms of the length of time that people spend in hospital beds, and not just in terms of sort of individual short stay admissions, but also in terms of longer length of stay. Well, we can sort of cite some of the data there, but particularly for Royal Derby Hospital, which obviously will be a key point of interest as a local hospital for the city. And we are seeing increasing numbers of patients who are waiting in excess of 7, 14 and 21 days in beds that we do want to obviously be able to move on to more appropriate care outside of the hospital. So it's a real issue that we have been working through. I've mentioned winter a few times, but we know that winter is not, the winter pressures are not limited to the winter time in terms of some of the historically when we've seen those pressures. And it's therefore about developing surge plans for key parts of the year. And we've got a very comprehensive winter plan that, you know, we predicted some of the risks and challenges that we would face, and we've put in place some actions which we'll come on to when we go through the slides. We've had 2 system critical incidents as well that we've called, and obviously communicated that with our stakeholders and with the public. One was for a few days before Christmas, and then a longer lasting one from the 31st of December till the 12th of January. And these very much were linked to issues around you know, our workforce, out managing those demands, and that flow through our hospitals, which meant that we had silver and gold level command structures in place where we would meet once, twice, 3 times a day sometimes to work through tactically how we help get the system flowing again, whether that's mutual support or other sort of tactical things that we would look to do. And then what we'll do now is we'll sort of say we'll walk through some of the particular areas, and what we've got just to sort of connect the story really is talk a little bit about the current performance for urgent and emergency care. Then we'll talk specifically around discharge as well from a performance perspective, Jane's going to cover a little bit about how our teams across health and social care work, particularly in the city, and how that helps us to work collaboratively on some of these issues. We've then got some data and some details around bed capacity. You're obviously very interested in Florence Nightingale Hospital, and we've also got a broader picture around some of the beds that we've got open, particularly around some of the surge capacity that we need at the moment. And then Kate's going to walk through a little bit about some of the system discharge work that we're doing and some of the more medium-term work that we're looking to develop time. So in terms of the first slide then, and obviously won't repeat any of those sorts of messages that I've just set out, I think it's important to... Shall I keep talking?
Yeah, it's back again now.
So I think sort of key messages here, and hopefully people have had time to read detail, but we definitely have seen spikes in demand in certain sectors within health and care. So definitely pull out from a 111 perspective. There were times pre and post Christmas when we were seeing call demands 50% up from what we were expecting and anticipating. That has settled now, but that clearly has added pressure into the system. From a 999 perspective, in terms of our EMAS provider, we've also had concerns, particularly over that same time period, both in terms of the length of time it takes for a response in the community when someone is phoned for an ambulance and needs urgent attention, but also in terms of handover times when the ambulance arrives at the hospital and hands over to the A&E staff. That hasn't been achieved within a timescale that we would be satisfied in terms of, making sure we're having that timely response. However, that has settled more recently, which will come on to some of the reasons around that, but it's encouraging that it feels to be more stable at the current time. And then we've got a range of sort of other sort of indicators here around trends. But as I said at the start, the flow into the hospital, so some of that walk-in activity and conversions into aren't necessarily high in terms of trend. It's more the spikes that we have to cope with over time. But the key point here and why we often struggle is because our beds are constantly full, but also over capacity in terms of escalation areas open as well. So we will consistently see both of our acute trusts within Derbyshire at 96, 97% occupancy, and really to have optimal flow through the beds, you're looking at being, at the maximum sort of 91, 92%, preferably lower. But we never at the moment manage to get to those levels. This is why we don't have the headroom really to be able to keep that flow going through, because we're so full and we've got extra capacity open on top of our core bed base as well. If we could go on to the, oh, sorry, did you want to take questions?
Yeah, that's all right, because I have a couple of points. One is just to explain a point really, and then so I'll just quickly ask you mine if you like, and then I'll bring everybody else in if that's okay. So I just wondered, this is just an explanation really of what it means, ambulance attendance to ED. Now we do know on this committee that ED means emergency department, which means A&E, because we previously had this discussion, but thank you for using the term A&E, because that's what most of the public understand it to be, even though I understand it does say emergency department. Nobody uses that term. But it says, what does this mean when it says remained positive with consistent low levels of conveyance to ED from I know what EMAS is, but I mean, what does that mean?
So EMAS will do their best to treat people, at home or city settings, as opposed to conveying someone in a vehicle to hospital, unless they obviously absolutely need to, in terms of that high level of category of urgency and needing support from clinical teams within the acute hospital. So there's things around, for example, that's called sort of hear and treat and see and treat, where either you have a telephone intervention or you can, for example, a patient might have run for an ambulance at home, and the paramedic could treat that individual in their own home and then not have to take them to hospital.
Okay, thank you. Yeah, I was a bit confused by that, because obviously what we do know is that there are fleets. There's a fleet of ambulances sitting outside the Royal Derby all the time at the moment, or there has been. So I just a bit confused by that, but I understand that. Thank you. That's a good clarification for me. And so I just wondered, obviously your you're encouraged by the direction of travel at the moment. That's what the slide seems to indicate in terms of the sort of decreasing wait times, etc., handover times. It says they're significantly reduced here at the Royal Derby because of handover times. But I mean, we don't. Do you have? Can you tell us what the average handover time is at the moment, please?
So yes, in terms of the most recent data, and as you can imagine, we look at this on a daily basis, often hourly by hourly, when it's really pressure. We have live data that we see ambulances arriving and being dispatched, that sort of thing. At the moment, in terms of the most recent data, and obviously all of these things are subject to validation, but we are at the 25 to 30 minute mark in terms of that sort of average handover time at the moment. It's different between Chesterfield and Derby at times, and sometimes there's mutual aid also that is provided if RDH, for example, is full and has ambulances stacking, then and Chesterfield was less busy, then that can happen as well.
So the Royal Derby, then, do you think it's about on average 25-30 minutes wait until they can hand over someone into it?
That's what it has been. I mean, as I say, we look at it every day.
Okay, we're not, that's fine. I think that's been the general trend in the last few days. That's absolutely fine. Thanks. We're not, right. That's the average. So some will be waiting longer, and some depending on.
Absolutely, and we could provide more detail about those trends. I mean, say sometimes it's been much higher than that.
Okay, thank you very much. Right. Does anybody at Diane sorry, Councillor Froggatt, Councillor Patterson.
On your 9 what we've just been talking about, it's got an average of at the moment of 25 to 30 minutes versus a target of should be 18 minutes. But then you've got a new target coming in for 23 to 24, and that aims to be an average of 30 minutes. So we're just moving the goalposts, aren't we? You're not saying, well, we're going to make it 20 minutes. You're just going to push it down the road, kick that can down the road and make it 30 minutes for the future.
So no, really important point to draw out here. So I suppose the first thing to say is that we absolutely aim to get to patients as quickly as possible, and obviously meeting the national targets, but just that timely access is so important, and we know we've got a lot to do to improve and to be consistently improving in that respect. The new target is mentioned because we have received our national planning guidance from NHS England, and the target for next year is an average of 30 minutes. But that doesn't mean we're going to be complacent of thinking that's that average. We absolutely, every single patient matters, and we'll be looking to get to those patients as soon as we can.
Thank you.
But is it true to say then, though, that the target times have increased?
So next year, they
will be increasing next year.
So category 2, which is for category 1 is the highest category. So category 2 is the next tier down for people who've been triaged in that particular category. It was 18 minutes, or is 18 minutes now. That's the national target. It will be an average of 30 minutes.
So it's going to be okay. Thank you. So that's quite a significant increase. I think it goes without saying. I'm sure I speak for every councillor here that we do not for a moment believe that any professionals working in the health service, anybody here, doesn't want to give the very best service that they can and want to get to people. I think that's absolutely taken as read. Nevertheless, what we know, and we all know this, is that things are pretty serious at the moment, have been very, very bad over the winter. Anxiety levels among the public are very high, and it's our job to scrutinise what's actually going on. It doesn't mean that we don't know that people aren't working really hard, but people are working really hard, and I know people in the city who do not have any faith anymore that an ambulance will come when they need it. So that's why we're asking the questions. But we understand that a lot is happening to try and make it better. But nevertheless, as it happens, we're getting increased time in the targets. Thank you. Oh yes, Councillor Patterson.
The 18-minute target, is that set nationally? That's not, so that those aren't targets set by us as an NHS.
The national targets, that's correct. Yes.
And our current for category 2, the average wait time 25 to 30 minutes. Do you know how that compares to like the national average for EMIS specifically? So how is our performance doing compared to what national average is?
So up and down the country, this is an issue in terms of response time. So we're certainly not an outlier for the East Midlands position. I say that this is a challenge position. We can absolutely share the detail, but from a benchmarking perspective, we are probably sort of in the pack, if you like, in terms of those averages.
So they're all about. And we only on this slide here only references category 2. So you said category 1 is the highest in terms of.
It's immediately life-threatening calls as well. So we have targets, different time periods, and obviously the higher the priority, the quicker that we need to get to the patient. So we have national targets set for each, and they're based on the mean, average, as well as the 90th percentile for each of those targets.
Is there a reason why we've only got category 2 on here and not category 1 if they're the most urgent?
So category 2 it was drawn upon because it's often a bigger area of focus. We tend to respond to the Cat 1 responses quicker and closer to the target than we do Cat 2. Cat 2 has been a much more difficult target to attain, and it has a lot of national scrutiny as well. But we can absolutely give you detail of all of the targets if that's helpful.
Thank you.
Yeah, thank you. And if I could just follow on from that slightly before I bring Councillor Lonsdale. We did have a presentation from East Midlands Ambulance Service at our last meeting, and I appreciate it is their service, it's not yours. But nevertheless, and I believe that within category 2, does that not actually include people who've had a stroke and people who've had a heart attack? So I think I will ask this question if I can, but just very quick, because, but I do appreciate that it's not your service, and the ambulance service is not your service, and you are also just responding to national targets. But my understanding is that people need attention from a stroke and a heart attack very quickly, or their chances of survival rapidly diminish. I mean, I've been given figures from these first responder units, which we tried to set up in my own ward, figures of something like 8 minutes, and after 8 minutes, and the damage from stroke. Now, I'm not a clinician, that's really clear to everybody, so I'm not pretending to know. I don't know if this is absolutely the case all the time, but clearly, we know that you will accept that there's chances of longer term damage or chances of recovery are higher if you need to be seen fairly quickly. So I mean, I suppose this isn't your call, is it? But I mean, it is concerning that the target is going to be 30 minutes for things like heart attacks and strokes. I feel that's concerning. I don't know why anybody else.
It's very concerning.
No, to take the points, I think it was what Councillor Froderick said. I think, for our perspective locally, we will aim to respond to patients as quickly as we can, and the targets are set nationally, set by the regulator, in conjunction with clinical input into that. I'm also not a clinician, so just to be clear, I'm certainly not talking from a clinical perspective. There are absolutely though conditions which have time factors associated with them in terms of outcomes, but as I say, these are the targets that have been set for the year ahead.
All right, well thank you. Councillor Lonsdale.
Okay, well, thank you for that. That was really interesting. I want to ask around the 96% of bed, the flow through. What is the solution to getting it down to the 91% you mentioned before? Is it a case of moving people faster? Is it more staff? Is it more? I mean, I know beds and staff kind of go together. So so what would be your solutions to that?
So, are you coming on to that in the next slide?
Is that? Okay.
We can do. I mean,
please feel free. Sorry, do answer now. Then, sorry, I just thought that's the.
No, absolutely, no, that's fine. Yeah, just reminded myself of the slides we've got to follow. I mean, these all go together, but yeah.
Please answer.
Okay.
Thank you.
Yes, so absolutely. So bed occupancy. I mean, there are all sorts of issues, some of which you've alluded to, Councillor. So I mean, trying to pull out sort of some of the key areas. So, I mean, it's absolutely about the data is really clear that people are spending longer in a bed. We're not necessarily seeing lots more people coming through the system. The length of time they spend there is significant. And for those really long length of stay patients, it absolutely does link to the lack of this sort of supply that we need in the community at the discharge level. And we've got some statistics and things on discharge, which we'll come on to, but we are seeing significant pressures in social care, which obviously aren't new issues, but they are absolutely contributing to the ability for those longer length of stay patients, often who need packages of care, to get them home or to a place that they would call home to happen in a timely manner. So that has to be a key factor in being able to reduce that length of stay. I'd also mentioned before that there is a higher acuity in terms of the level of clinical condition of individuals, which often then means they need to stay for longer. They need more intervention and more care before they move on. We don't always,
because people are not getting intervention early enough, or is that because people are sicker? Are they getting intervention? Is it because people are waiting to actually come and see a doctor before they come and see a doctor and getting themselves more
I
sick?
think you missed the operative word, able to see a doctor.
Yes. Well,
so as with all these things, there are multiple factors. I mean, we're working really hard to develop longer term strategies around prevention, and obviously people being treated earlier, or prevention from ill health, so that would absolutely play in. We don't yet fully understand some of the impacts from COVID, and how that's also impacted on people, whether they coming forward early for treatment and outcomes, etc. And there'll be lots of other things as well, thinking about long-term conditions, elderly population, more aging population, and growth in that level. So all sorts of reasons, really.
okay, thank you.
Councillor Patterson.
On bed occupancy, are there issues around where beds are being occupied? Doctors, nurses, whoever might feel like they no longer need to occupy that bed, but are there difficulties around people who that bed could be used for somebody else, or doctors and nurses might feel like there's somebody who is in more need of that, but the current occupant, is it difficult to get them out with certain beds? So basically, if you see what I'm getting along the lines of, is there a significant percentage of people who are occupying beds who, say in the hospital, who don't necessarily need that bed or could be at home?
Yes, absolutely. So at the moment, and over sort of the winter period, between our two acute trusts, and obviously the Royal Derby being a larger organisation, often more numbers are there, but about 200 to 220 medically fit for discharge, as we call them, patients who need to be cared for elsewhere, but we can't sort of move them on to that most appropriate place. So it is significant. I think
what are the barriers stopping that?
So it's things along the lines of the social care support for them to have a package of care to be able to be cared for in the community, or in care home settings, or even indeed to go home with domiciliary support as well. So it's all those sorts of issues.
I know Councillor Webb has come to talk to us tonight because we wanted to ask you about the council's response to the social care problems, Roy. And I think what we'll do is we'll carry on with this presentation, if you like, and then sort of bring you in towards the end, Roy, if that's all right. And I know you've got some more to say on that as well, but thank you. Right. Would you like to carry on?
Yeah.
No more questions on that slide?
No.
Thank you.
So we've also talked on the previous slide about some of the national standards around the 999 service. This draws out the A&E 4-hour target, which I'm sure people are familiar with, and it's been a target that's been around for a long time. We understand that next year there'll be a new standard of 76%. So 76% of people attending A&E needing to be sort of treated or admitted within that time period. For context, in terms of the main emergency department performance for the Derby Hospital, the year-to-date position, so going from April of last year through till now, is close to 70%. But that also includes other activity that we count as part of the sort of the overall data return, which is in line with the national data collection guidance, things like urgent treatment centre, walk-in centre activity, as well as the main emergency department. Royal Derby does struggle with maintaining good levels of performance on the 4-hour target within its own department, and we also see that in the Norfolk County within Chesterfield. It's also a national issue, but we know we've got a lot to do to better understand how we can improve some of those things. But there is a direct correlation with being able to move people through the A&E department with what's going on in the wider bed issues that we've already described. So happy to take any questions on this slide.
Can I? We're going to be a competition to come in on this. Can I say something first?
Go on, I've got pitch line.
Agreed to. Well, I'll ask just about clarification first, and then I'll. So just a clarification. I mean, that is a very interesting qualification that you just told us, actually, that the figures that we have are for things like the walk-in centres as well. So just as a matter of interest, do you know the figures for what people, know A&E at the hospital? Do we know what those figures are?
Yes. Whether these are the. I'm sure I've got them in here somewhere, Councillor. I can. I mean, it is much lower. So I please don't quote me, because I'll just check the exact numbers. But say close to 70% for all of the different types of A&E activity. It's probably closer to about the sort of 40% mark in terms of just what we call type 1 performance.
So it's actually, so when people say, waiting times in A&E, which is especially the emergency department at the Royal Derby, it's actually, only 40% are actually seen within 4 hours.
In terms of that particular site, I suppose what's also important, though, why I think, obviously the public recognise A&E as walking through that main front door and being treated in that department, but we have other things like GP streaming. So a GP would see an individual and triage them and maybe treat them or signpost them to another service, which means that they're not then spending a long time in the A&E department when they might not need to be there. But we also encourage the public to go to urgent treatment centres and other facilities where they might actually be seen quicker. So
I appreciate that, but actually, what the thing is, okay, I'm going to let Councillor Foggett come in, but the thing is, I think that figure of 40% is quite important, because I mean we are kind of, I think we're all aware the debate around whether everybody who's in the actual A&E department needs to be there, but I have had to visit it myself, not for myself, but for a relative in recent months. And I have to say, it was actually one of the most upsetting sites I have personally experienced for a little while. There was a fleet of ambulances waiting outside. You go in, and I don't know. I don't want to sound alarmist, but I haven't been in a war zone, clearly. But it felt like a war zone, the atmosphere. The staff were excellent. They were very calm. They were very focused. But there were people everywhere. There was a general air of despair. And there was a lot of people waiting for a long time. So to my mind, the 40% figure is very consistent with what you see when you go there. But I think we all do accept that not everybody needs to go to that department. But thank you, Councillor Foggett.
Yeah, I'm not getting at you, trust me, honest. It's the people at the top of NHS England. They've already moved the target time in the previous slide. Now they're moving another target from 95% to 76%. Now everybody knows it will be easier to hit a target of 76%. In my day, when I was at school, it was to improve. This isn't an improvement. This is a kickback all the time. And the 4-hour target was placed in 2004. Nearly 24, and it's going backwards. So I don't know how you get to the top of NHS England and tell them this is not acceptable. You know, for the people of Great Britain, basically, because it affects all of us. I don't know. To me, everything is just going backwards. Yes, we've got a more ageing population. We've got this, we've got that. But if we're all still here in 24, and then they come again with we're hitting our targets now at 76%, and everybody go, oh yay! But it's not, because.
You mean if we're all still cancer?
Yeah, if we're all still cancer, we're all sitting in this room, and you come again and you say, yeah, we're reaching our targets of 76%. Everybody will be happy, but it's not. Do you know what I'm getting at? It's just not acceptable.
Yeah, well,
and I'm not getting it honest.
No, don't worry, I'm not taking it personally. I totally understand what you're making it. Absolutely, councillor. I suppose I would say, though, that a bit like what we're saying about the ambulance response times, we're certainly not happy with low levels of performance. And regardless of the national target, there is a person and a family often at the end of each of these numbers. And if we can crack this issue around flow into the hospital, through the hospital, out the other side, then actually we will see high levels of performance, much in excess of the national targets probably. But there are so many issues, some very sort of immediate things that we're working through, but also some long term things. You know, our workforce plan we need to better understand. There's lots of things. So target might have been lowered, and I can't really comment on what's been set out nationally, but we absolutely want to improve, and that's
Councillor Lonsdale.
So, okay, so those are the national targets. They're set from on high. Do we have local targets that we are trying to get to locally that are that we'll take that as our baseline, but actually we could do the 95%. We want to aim for the 95%. Do we have that sort of attitude rather than oh no, that's the basics. We'll just hit that. Do you know what I mean? Is it an attitude of excellence rather than an attitude of we can manage?
Absolutely. I think that there's a balance, isn't there? So there's the reality of the current challenges and how we are performing. So for me, it's about being able to demonstrate consistent improvement, and therefore every bit of improvement we make, we're having a more positive impact on individuals. So that's really important. In our system, we have what we call delivery boards, which is a sort of partnership approach across our joined up care Derbyshire integrated care system, where each programme is managed by a delivery board. And this week in our urgent emergency care delivery board, last week, we were talking about the sorts of targets and success measures that we want to put in place to make sure that we can really see that tangible improvement. And that indeed happens across other delivery areas as well. So no, absolutely, we do have a can-do attitude, but we recognise the difficulty of some of the challenges that we face.
Councillor Khan.
These improvements you're talking about, have you got deadlines to improve these deadlines, these improvements? Have you got some sort of a plan that next 6 months we'll be improving waiting times, we'll be seeing patients more earlier and meeting them targets? So have you got all that when are you going to meet all that, or is it just we're going to improve like we've heard that before?
So really helpful question. Thank you, councillor. So it's a mix of things here for us. So I mentioned that earlier, we look at things on a daily basis. So actually in that sort of snapshot, immediate way, we are just looking for, can we improve on yesterday, and is the trend moving up? But what we tend to do on a larger basis is we tend to plan for the year ahead. So we will say, where we want to get to at the end of that year and almost what the milestones are to build up to that. So we do both, because I think some very operational day-to-day targets we need to look at on a more regular basis. But we also do longer term planning as well. So it's a combination of the two, but it is about improving and consistently showing that upward trend.
Councillor Patterson.
My question doesn't necessarily directly relate to the first two slides, and I guess not specifically to the discharge, but I thought I'd be here and ask it anyway. In terms of staffing levels, say specifically for Derby Hospital, do we have enough doctors in there at the moment? Do we have enough nurses, or is that a challenge in itself that we're short on numbers at the moment? Recruitment or training more doctors and nurses, is that something that could help also improve these waiting times?
Yeah, I mean, there's a combination of issues, and apologies, I don't have workforce data with me, but we can absolutely share some sort of key messages if that's helpful outside of the committee. But I mean, it's true to say in an organisation like the Royal Derby, quite a large acute hospital, there'll be pressure points in different specialties, in different clinical professions, and that's true of many hospitals. So I don't think there's anything different or unique about the Derby Hospital, but absolutely there are pressures. One of the things we look at is how we can recruit to permanent posts rather than use of bank and agency and that side, which is often more difficult to fill shifts and rotas and those sorts of things, which do cause pressures at times. And we also obviously look at things like sickness absence and turnover and how we can make sure that people stay within the organisations and help us to deliver the services. So yes, there are areas that we absolutely need to do more. With more details through the national workforce, I expect that will help us locally to have a more comprehensive plan about how we tackle some of those issues.
I'm sorry to keep pressing this. I was just on this slide. I know we need to move on, but it is so important to people at the moment. All of these issues, I cannot exaggerate how much this is worrying people in the city. So we've got this figure of 40% at A&E, but then I wonder how you define being seen, because I mean, I've seen it myself, being there with a relative, and I'm sure other people have got far more experience than I have, that there's a process of my relative was actually seen quite quickly. It was actually admitted quite quickly, but the seeing was just a quick monitoring, a line put in, and then it's a wait. And the wait, actually seeing the doctor was about 10 hours. So then, I'm not being disparaging about the attempts to offer. I mean, certainly the immediate monitoring is obviously relevant because obviously they've assessed that it's not an immediate emergency and somebody can wait 10 hours. But I think this thing about, well, we've got to be seen within 4 hours, I'm wondering to what extent that really does give us any kind of accurate picture of what's really going on, because many people go to A&E and they're spending, 12, 14, 15 hours in A&E overall before they're actually kind of dealt with, really.
So the 4-hour target is obviously one metric. Within that, there's also, sort of a broken down level of target. How quickly will someone, from the moment they speak to the receptionist, how long will it take for them to have an initial triage? How long will it take to actually be seen by a doctor if they need to be seen by a doctor, etc. So there are nuances to the overall headline. There is also, which you might be familiar with, is the 12-hour target around when a patient is being admitted, how long it takes for them to go onto the medical assessment unit or onto a ward, so to basically be in a bed outside of the A&E department. And we do have, unfortunately, and it's not something where we want to be. We do, as you say, sometimes have patients waiting multiple hours whilst we're trying to find them a bed in another part of the hospital to move on to. So that is also really closely monitored, and we haven't covered it in the slides here, but there is a level of detail in the plans from NHS England for next year around these, as they're called, 12-hour trolley breaches. So basically making sure that people, once there's a decision to admit someone into a bed, that they're not waiting a long time, although 12 hours is clearly a very long time to go into a bed. So there are other targets as well, I suppose, the point I'm making.
So just for clarity then, what does the 4-hour target relate to? What is it to be seen?
So it would either be that the patient is triaged and decided they don't need any treatment, they can go home, so the clock would stop at that point. It could be that they do need to be admitted into a bed, so that decision to admit is made, but obviously the clock is still running against that 12-hour target. So it's being seen and a decision made, with an outcome to it.
Right. Okay. So it's actually, thank you. So basically, that's pretty much, it is what I described. Then you are literally seen in the sense of someone sees you, assesses your initial position, that's being seen, and then how long, and then these are the targets.
No, so it would also be, so you'll always have an initial triage, and often that can be within minutes of arrival. But then if you need to then see a doctor, you need to, some sort of intervention in the A&E department, then that would still be within that time. So it still need to be within 4 hours. If there's a decision to admit, there's then this 12.
Okay. So in the current context, actually getting to see the doctor in A&E is quite a meaty moment. So that is quite a meaty requirement to actually be seen by a doctor is within that 4-hour target.
Should be, yes.
Okay. Thank you. Thanks. Any more questions on this side? Okay.
So can I just go back to that a second? Because I'm slightly confused.
Yes, you can.
Because I thought before that you said that there can be there's different triggers for having an initial assessment to then being seen by a doctor. But then at the end you said that 4-hour figure is getting to see a doctor. So my understanding of what we said, what we've just said is, so you go in, you see a receptionist. I've been to A&E because I tend to break bones. So I'll go in, I'll see a receptionist. There might be someone there behind reception who will take an initial look at me, and then they'll sit me down in the waiting room. And from my experience, that 4 hours is from me sitting down in the waiting room to being taken, say, round the corner through the double doors into a side room to get assessed. So is that the 4 hours?
So you need to have left the department or a decision to admit you into the hospital. That would stop the clock, if you like, on the 4 hours. So you might see the receptionist, you might be triaged, have some initial observations made of your condition, etc. And you might then be in the waiting room for a longer period of time to see a doctor. The 4-hour clock is still ticking at that point.
Right, okay.
So when you've been taken off for your scenario, your broken bone,
Yeah.
to get your X-ray done, that would be the digging top would be that's the 4 hours. Okay.
Until you've been put in plaster and left the department, you're within.
Okay.
All right. Thank you. Would you like to carry on, please? Thank you.
So I think we're going on to discharge now. Obviously happy to take questions, but this was just to remind the committee of some of the things we've talked to you at previous meetings about, but just when we do start to get into different pathways of care, this was just the definitions, which goes from pathway 0, which is people going straight home from hospital without any need for further support, right through to pathway 3, where you need sort of 24-hour nursing care or residential home care with that level of support. So happy to take questions, but that's just a sort of positioning slide really, so you're clear when we mention some of these things later.
Councillor Froggett?
Yeah, just a query. How on the I need a temporary community nursing bed, but they need actual medical nursing. Oh, I mean, I might know this better than anyone. How many in Derby, Derbyshire can give that support, as in having a medical experience to look after this person if they want medical conditions?
Sorry, Councillor, can you just repeat?
If you go into social care, it's basically Alzheimer's and what have you, and they just whack your bum and feed you. Yeah. If you've got complex medical needs, like if you come down to the hospital, you need your dressings redone all the time, and you've got this, that, and the other. Do we know how many actual homes or medical buildings there are that can cater for this sort of patient to come out of the hospital?
I think we answer that question a bit later on. What we're talking about is community nursing beds, and they're in the community hospitals.
Yeah, but on here it says complex medical conditions that require specialist knowledge of registered nurses.
So what we're saying, these are the pathways when you immediately leave hospital.
Yeah.
So this is for where your next stage of your journey or your next assessment. So where we've got there, I need temporary community nursing bed. That's not a lot. That's not in a nursing home. That's in a community hospital where you'll go maybe for rehab or some therapy. So, continue your assessment.
How many community hospitals have we got in the city?
Oh, not the city, no, we're talking about Derbyshire, aren't we?
Perhaps, yeah, well, perhaps we should go
Yeah,
on to
move
the
on.
next
Let's
slide.
move on.
So, no, because
Keeping numbers a little
it
bit.
is, yeah, it is very relevant, and it'll come back to
Yeah.
stuff that we want to say about the Florence Nightingale scenario, because
Put
it
in that one.
has
Yeah,
been a point
Put
of,
in that.
yeah, interest for us. So, yeah, I agree with Councillor Froggatt that I thought, well, pathway 2B is quite an interesting one, bearing in mind the reports we had on the rehabilitation wards in Derby, which obviously we were asked to support the complete closure of them 18 months ago, but we'll come back to that. So if you'd like to continue, thank you.
Okay, so the next slide is, as I say, just bearing in mind those definitions. What this basically is showing that we do have, again, targets with NHS England about how many people following their acute spell when they get discharged, how many typically should be pathway 0 or pathway 1, so going home potentially with a bit of support if it's through pathway 1 domiciliary care, or the sort of higher support through P2 and P3 as we call it. So we are sort of exceeding from a Royal Derby perspective that target, and our mantra is always, you know, where appropriate, obviously patients is getting them home and being in their own bed is the best place to be, etc. So in that sense, we are sort of in line with what is expected nationally. But as I said, sort of earlier in the presentation, where we do struggle in terms of the timeliness of that discharge is absolutely through that sort of the flow issues that we have within the acute spell. Happy to take any questions.
Councillor Froggatt.
So you get used to me. I'm a little confused now. I'll join Councillor Patterson. We've got the targets of 95% and 4%, 1%. What are the actual numbers? Not, 95% of how many numbers? It could be 95% of 50. What are the actual numbers of people being discharged in these percentages?
We'll absolutely give you some discharge numbers, but it still is that it's about the proportions here. That's quite it's. I mean, sometimes percentages. You're right. But in this context, it is about as many people as possible going home without needing any support. That's the expectation.
Yeah, the thing is, the people that are going out that want support, and it's got 0.3%. Have we got enough facilities in Derby and Derbyshire to cope with this 0.3%? So as I say, you've got numbers here, 24 beds, 86 beds. So how many beds are we looking for from the patients that are being discharged in that 0.3%?
That's a move on as well.
That's a future slide.
It's
Jumping forward.
I'm
on the
jumping
next
on.
slide, isn't it? But
in terms of the percentage of it's of every person discharged, so all the people that go into Royal Derby, of all that's the 100%. So it's everybody every day that comes out of Royal Derby. That's the 100% figure.
So if you had 100 people in,
You know,
100% to
go straight home.
So it'd be 2,000, 3,000.
and you'd keep 5 people in the hospital.
Yeah, but it's 2,000, 3,000. There's a difference between 30%, 3% of 1,000 or 3% of 20.
I think would it be fair to say, because I think we just need to move to the next slide, but I think would it be fair to say though that in terms of the impact, three small percentages have who aren't able to be discharged or whatever, as you might expect, have a significant impact on the hospital's ability to function well, because 3% of the overall number, I don't know what that is, as Diane said, we don't know what it is, but say if it's even if it's only 20 people, because it's 20 hospital beds we're talking about, that's an awful lot of people who are creating problems. Like just 20 people can cause big problems.
So in terms of the delays that we can quote some data about it, just to answer Councillor Froggatt's question around what's the total, but Typically, Royal Derby will have 13 or 14% of all of their beds, I don't like the phrase, but blocked by individuals who need to be moved through the system and out of those beds. So, you know, on a bed base of close to 1,000 beds, in terms of their core beds, 13, 14%, you know, it's a significant number. And as you say, that does affect the overall functioning of the hospital.
So it's 30 to 40%.
13, sorry, 13.
Oh, sorry, I didn't quite catch 13 to 14.
900 odd beds that they have in terms of their core beds are the patients that we call are medically fit for discharge.
Okay, thank you. Should we move on? And then I think Diane will get her answer. It's on the other subsequent slides, isn't it?
Thank you. So Jane's just going to very briefly just outline what.
Yes, so this is as you can see, this is an overview of Derby City Social Care and the established Community Health Services model. So this is the model that we've got operating now based within the Royal Derby Hospital. We are an integrated discharge team with our county colleagues, with our health colleagues, and with Derbyshire Community Health Service colleagues. We are firmly embedded in the decision making across all the wards, all the departments, and all our pathways. I don't want to go through each individual box, but I would say an important part to notice here is that based at the front door, that's another euphemism for ED or LNE, we actually have a Derby City Council social worker who's actually based 7 days a week at the front door. And they work very closely with a department called the Frail Elderly Assessment Team. So that is around preventing admission into hospital or from short stay wards into longer stay wards. So we will look at that. If there's anything quick, short-term fix that we can do to get that person home with preventing a hospital admission. Often we're working there with people who are, shall we say, quite regular attenders for whatever reason. We know them very well and we can talk to them and quickly get things sorted out with accommodation or with their families or with workers in the community to get that person back home. And that's a really, really important role. We've also got a discharge assessment unit now within the hospital, and this was set up in response to the pressures under COVID, where we had new response times to discharge people from hospital. When you're medically fit and able to go home, you should be moving from your hospital bed within 2 hours. Now, that can mean that often people aren't ready for their medication, they're not signed off, or they could be waiting for a piece of equipment, they could be waiting for us to arrange care. So actually, rather than sitting there at the side of your bed and somebody being on one of the trolleys can't come into your bed because you're waiting on your medication, you can now come down to the discharge assessment unit where my team are based, and you can wait there. And you can have your assessment, and then you may need a piece of equipment or your medication, or you just might need to be waiting for the result of the blood test. So that's a very, very useful thing. And we can accommodate between 30 and 40 people in the discharge assessment unit at any one time. We also, it's not just people who are able to we've got people that you might be waiting for a bed in a community hospital that's not available at that particular time, say in the morning. We can move you into a side room, you can receive your full nursing care while you're waiting for your transport, and then somebody can come into the hospital bed who needs that acute care. So we set that up in COVID, but it proved to be very, very useful and is now fully embedded.
Well, it sounds like a really positive development.
It is a very positive. Yeah.
Any questions, Councillor Froggatt? Holmes, Councillor Holmes, you want to come in at some point? Please do if you want to.
Yeah. Don't be frightened.
Don't worry.
No, I was just going to ask, of course you're moving them out it's good that we're making room
Yes.
for
Yes.
the people coming in the front
Yes.
door, trying to get them out the back door. What is the average time wait of somebody coming to the assessment unit and then
Well,
being moved on?
okay, so
Or have we got targets in there as well?
we do have a target. You cannot be there for more than 48 hours. If you come down and we, for whatever reason, and we haven't been able to get you to your next stage of journey, you then will be readmitted back onto a ward. But it is fully staffed, obviously day and night, as a hospital ward would be, with a matron, sister, a medical team, etc.
So you said they'd be readmitted to a
You
ward.
have to be readmitted.
So how would that bed become available if they're still waiting for a bed at the front door?
Well,
Do they keep some available just in case you don't
then,
come?
well, no.
Or do you go back and sit on the trolley?
Well,
Door.
you obviously come back into the bed bureau, don't you? Where's prioritising who goes where. You may often be an outlier in another ward, but we firmly don't think people should stay there for over 48 hours. So we do ask really if people are coming down, that they come down with a plan, that we know what we're doing. However, when we had the critical incident, people did come down without, and it was without necessarily having a plan. But then you have to weigh up that there's again people at the front door, people on the trolleys. It's very, very difficult, but it is successful. So as I say, we're firmly integrated and embedded with DCHS, and we are a hospital social team. Now, in some areas, the social teams have been taken out of the hospitals. We didn't do that. We decided that we thought the best way for serving the Derby City was actually we would see you within the hospital, but not just within the hospital. We will see you within the hospital when you move into the pathways that we talked about, pathway 1, 2 and 3, and we will work with you and with our therapy colleagues, and we will complete an assessment. Rather than doing those full assessments within the hospital, discharge to assess model is let's get you to the next stage of your journey where we can have a look at you out of the acute setting, because people, for loads and loads of reasons, tend to be less able within a hospital setting than when they're at home and within work with you until we know what your next stage of care looks like, and we can then commission long-term care services if you require, and then we will follow you up again at 6 weeks, and then we will hand you over to our community.
That's good. It's really good having the assessment unit there, the Norling House.
Fantastic.
Yeah. Thank you.
Any other questions at this point? Shall we move on? And I'm aware this item's taking a long time. We usually are quite short on our items if people have not been here before, but I do think this is such a critical issue at the moment that we're spending a lot of time on it. Thank you.
Okay. So this is sets out I think there was a question earlier around the facilities we've got in terms of bed capacity outside of the acute trust and within the community. So you can see here, obviously I won't read out each line, but these are effectively where we have beds for our local population. So house in the city, we've got 24 beds, and then we've got our community hospitals across Derbyshire, which are obviously for city and county patients to access. I know there's some interest obviously in Florence Nightingale, which we cover, but one of the rehab wards is absolutely being used in terms of that additional surge capacity, which we talked about at the start of the presentation, which we've got. We've also got some beds available at the Ilkeston Community Hospital, and then beds which are coming online in care home settings as well. to take any questions.
Thank you. I mean, I will just make a comment, if I may, as the chair. The rest of the members will indulge me with that, because this is so frustrating, actually. I'm sure the people who were on this board last year will feel the same. That we had this presentation it was the London Road Community Hospital then, closing the 3 rehab wards. We rejected it. We said it wasn't a good idea. We were not convinced by the plan. We were told that there would just be 9 rehab beds in Derby, and they'd be in care homes. There would be obviously some rehab beds across the county, but Derby would manage with 9 rehab beds in and all be very happy. And please, would you accept that we are going to permanently close these rehabilitation wards? We totally didn't buy it. We asked the managers who were dealing with that change proposal to come back and talk to us again, which they did. They tried to blind us with stats, and we didn't take it then either, because we are not, I am certainly not an expert on this, but instinctively we knew that this was wrong. And I know, and it is wrong. It was wrong. So it is frustrating. I mean, I don't know. So this is my point. So I'm going to bring other people in a minute, but I hope that I mean, you know, this scrutiny board, you know, the councillors, we know our ward residents. We've got our own experiences. We're not. Some of us work in. Some people do work in the NHS. I don't think there's anybody here who actually does. So we're not experts. But I think when something is clearly wrong, then it just smacks you as absolutely wrong. And I really hope that people will actually listen to it just as a plea to Chris Clayton and join Derbyshire and everybody, because, you know, this is wrong. So at the moment we have one of the wards is temporary. Is that a temporary reopening? Do you know of that ward at Florence Nightingale? Is that one ward? It is, isn't it?
That's one ward. That's
Yeah.
45.
The other one is obviously a hospice. Is it so? There's just one ward that's reopened. Is that right? Yeah.
Yeah, it hasn't opened up as a rehab ward.
No, it's just a surge ward.
Yes. Yes.
Right. So we're still plans to continue with 9 rehab. So once we're all back to normal, whenever that is, and when we get to this world where we have all these people who we can recruit to Home First, when we don't have these, you know, post-pandemic problems, winter flus, aging population, when we don't have any of this going on, and then other things that are unforeseen, and you know, when we obviously have a declining rather than increasing population in Derby, then we'll be able to work with it. Are we still hoping that we'll be able to go back to that model of not having any extra beds, or in Florence Nightingale, not having 9 rehab beds in care homes? Is that the plan?
So could I just make a broader point? Yeah. Sorry, Jane.
Yeah.
So we haven't gone away from Home First. Home First is.
No, indeed, I know. We were told that's the answer. The problem. Sorry to interrupt. Yes, the point is that everything is being pitched on Home First, and that away from hospitals, people must go home. That was what we were told. And actually, you know, we don't need these rehab beds. We were told we don't need them, and we only need 9. We might buy on an ad hoc basis in care homes. But I don't think what's happening suggests that plan is a good one.
Or it was but the cart was being put before the horse, particularly if it is the way forward. It was being done in the wrong way round.
Well, I work with those customers who went down to London Road prior, and we didn't have the community hospitals then within the community, so people needed to go for embedded hospital rehab. They went down to London Road. Now, when that closed, then we got the community hospitals on board. So then we've now got the 86 beds in community hospitals.
Indeed, and I know that was the plan across
Yeah.
Derbyshire, and there'd just been 9. I'm sorry this is something that we are specifically asked to have a report on, as well as the discharge issue, because it's all related. And I know you were not the ones who brought the initial reports to us, but we know that we were told there'd be a nice amount of nearly 90 across Derbyshire, but in Derby itself, we were told that there wouldn't be any except these 9 that would be perhaps all in care homes. So is that still the actual overall plan?
The intention, as I was saying, was to focus on getting the right capacity for the right need. And I've just been able to find the stat about, you asked about the people needing pathway 2B, so the community, the people needing that nursing and rehab. And in the last 12 weeks from Derby hospitals, so just United Hospitals Derby, there was 87 patients. And there were 47 requiring P3, so going straight into nursing care. So out of the 14,700 people that went in and out of the hospital in total, the numbers are quite small. So the numbers at the moment that we're needing to have beds open and holding people, they're not people whose assessed needs in that capacity. So I think in terms of at the moment, we haven't got a position that says exactly what that number needs to be. And I think the conversation about the timing and the expectation, I think that the fact that we have the surges and how difficult this winter's been wasn't predicted at that point when that was.
No, indeed, no, I think that was the point, and we are, sorry to interrupt. Sorry.
So it's about modelling again. So going back to that approach of having using those same pathways and having capacity in the right areas to meet that need, but with a belief that actually the numbers of assessed need is actually quite low, now whether it's for 9 beds worth or however many beds worth, but that still would be the ambition.
Is the plan for the Florence Nightingale's rehab wards then, is it still to permanently close them and just to have the 9 beds, rehab beds in? Is that still once we're beyond the crisis scenario, whenever that sort of particular heaven will appear, is that the actual long-term plan?
It's about having the right number of those beds, where those beds would be, I think is still.
We need to work that through. Absolutely haven't made it.
So is the plan still to permanently close the 3 rehab wards? Because when I asked about this, I was told they had not been permanently closed. They're just temporarily not used.
They've never been permanently.
But they're not used.
So it was obviously when the pandemic started, we needed to clear as many beds as possible.
No, I think with respect, I know this. So just because I'm really aware of the time, and I feel I'm really pushing this and going on quite a lot, and we do need to move on to other reports. But I just said basically, in answer to my question. So is there an answer to my question then? Is the position still that those wards will be permanently closed?
So it's Kate's point about we need to set out what we think the future demand will be. At the moment, they're being used for this capacity. I think it's really important though that the committee do recognise that there are always risks of putting patients in the wrong types of bed. And
so at the moment, there isn't an overall plan for what to do with those wards at the Florence Nightingale. Is that the position?
I think the simple answer would be yes.
Okay, thank you. Right, so, okay, because before it was definitely the pathway was to be permanently closed. And the last time I asked about this, I was told that they would be permanently closed. But at the moment, given the present crisis, you recognise that you may need some extra beds in that hospital, but exactly what type of beds you needs assessing. Is that correct?
Like the where those beds are might not need to be in that hospital. So I suppose it's not about that. It's about the beds and then the options for where the beds could be, rather than a discussion about.
So where might they be then if they're not there?
Well, that proposal about to have commissioned beds in a care home setting.
So it is still the same principle that we looked at before then.
Those options.
Okay. Well, I've really thank you. I've really pressed on about it. I'm going to bring it to Councillor Froggatt.
Yeah, just 2 points. The residential homes purchased 19 beds in January, last week basically. Have they already been filled?
They're actually the number of beds that we've that we've commissioned so far, actually some of those people have now gone home. So it's not a block purchase of 19.
Yeah.
So we've spot purchased those as we've required them. But our aim there, it's not for people to stay in those. They're people, rather than having to stay in hospital, then we can actually offer you that. Would you prefer? We can't get you home for whatever reason, but actually you can go to residential home and you can stay there until we get you home. So that's how many people have gone so far, but they're not all there now because we're trying to work on 2 weeks.
Yeah. So who actually purchases? Is it the NHS or the council?
Using hospital discharge.
Right. Thank you.
Okay, I think I'm just so mindful of time, and I know we really don't normally take this long, but I think that we did specifically ask for a report on what's happening at the Florence Nightingale. Maybe we should return to that at another time then, because it seems to me that the same kind of plan is still in place, and it failed to see why people are better off in a nursing home than they are in a ward in a hospital. And I felt, I feel that the system doesn't, well, I think it leaves the system exposed, as we've seen in the last couple of years, this winter. So I'm not at all convinced by the current plan, but at the moment it seems unclear what the plan is. So maybe we'll come back to that. That's all right. So can we just, should we move on very quickly then, because we do need to end this item, but thank you.
I'm in the interest of time, I'm happy to take questions rather than presenting this slide, if that's okay.
Okay, we have sort of covered a lot of these points, haven't we? Does anybody have any particular questions here? Right, and the next one, please.
So again, happy to take questions, but this basically sets out some of the work we're doing as a system. We've got a dedicated a senior lead in place to help us manage our discharge flow work.
Okay.
Then the final slide is just setting out some of the specific things we've done in the city in terms of that proactive work to improve discharge, to increase capacity, to work with our partners on some of the things that we think will have positive impact on people. So
thank you. Are there any questions on these points? Councillor Fockett?
I'd just like to know how closely you work with residential homes and care homes in the private sector.
Very extremely closely. They have been big supporters of hospital discharge and have worked very flexibly with us. I mean, care homes are set up really for taking long-term hospital discharge, long-term customers.
Yeah.
But they have been very flexible. Now we have where say they'll work with us for 2 weeks, and also they will work with us to rather than being responsible just to care for the person, they'll work with an enabling model with us. We've got therapists going in, occupational therapists, physiotherapists into the residential homes with a view to getting that person home, and they will work with us to do that. So it worked really well.
Can I just ask the question? I mean, it is a case of supply and demand, obviously. Do they try to get extra charges from your funding? He said, because they all have a set rate, but when they know they need less than 4 beds, do they?
Yes, hospital discharge does come at a premium.
Yeah. Hope so.
I think it does still beg the question, if I may, why we can't have that kind of step of just, rehab or beds or whatever, whichever category or pathway it needs to be within the NHS, or why while we're buying them from care homes?
We do. So Perth House, which is our pathway to A, which is for resident people who cannot go home, but they require a residential type care short term. That is staff both joint but health and social care and funded care fund. And then if you can't go to that, then we would look at the community hospitals before ever we look at residential and nursing care. That's the pathways.
Okay, thank you. But of course, all those community hospital beds are not in Derby, are they? They're in Derbyshire.
They're in Derbyshire.
Yeah, so for some reason, Derby was deemed just to need these 9 beds, which I know 9 is a figure you won't recognise, but believe me, we heard several reports on this and we were told this had to be the plan. So there is, I'm very sceptical about that really, but thank you. Any other comments at the moment from anybody else? No. So thank you so much. Before you go though, I wonder if we could just turn to Councillor Webb. Thank you. I think that's the longest time anybody's presented, certainly any board I've ever been in. So we realise that was quite a grilling, but it is. I also don't recall a time when an issue has concerned people, worried people, and has been so in such a critically bad situation. So thank you. So it is very important. Thank you, Councillor Webb. I know. Thank you. We invited you here because we asked you. We were talking about this at the last board meeting, and we wanted to basically. We know there's a shortage of social care staff, which is a national problem. We know this, and we know the difficulties in recruitment, which are national. But we know that this is feeding directly into this problem, as has been said tonight, of getting timely discharge from hospitals, the recruitment problem. So we wanted to bring you here to talk to you about to ask you if you could tell us what the council's doing to try and recruit more social care staff.
We have a social care team that works specifically, as you've heard, with the hospitals on discharge and on issues around discharge. Bear in mind, prior to COVID, that there was no bed blocking in the city. So, we are coming from a base where we had never seen beds blocked before. We've changed the pathways, and in Derby, we are not blocking beds to the extent that other areas of the East Midlands, West Midlands are. So we are quite high up with the issues around this. We've got, as you've heard, permanent social workers working with the teams to help discharge. We've even put in local area coordinators. So we have one in A&E and one in the discharge team. And those local area coordinators, although they have a prevention role within our wards, and each ward has one across the city, they are in the role of getting communities to support residents when they are coming out of hospital. Bear in mind, that's the 97% that actually don't need to have any further treatment in hospital. We've got the Perth House situation whereby we've got discharge to assess for those people that really need an assessment before they can go back home safely. And that's where the local area coordinators come in again, because they're part and parcel of the community network to get those people back up and running again. And with regard to our team of social workers do a brilliant job, but even saying that, then I have written to the Secretary of State expressing concern about social care and about the way they are funded, about how we need proper pathways for our staff, a progression pathway by which they can improve. We've got a lot of work going on with the University of Derby, and we do find that when people come for social work placements, that if they are educated in Derby, then they tend to stay in Derby for their social work placements and make it a permanent move into the city if they're from elsewhere across the country, as you do get with the university. So we're doing what we can. We've got the new integrated care system, which is working between the local authority and the health service. That deals with the 80% of needs of people to keep them living healthy lives longer. We've got the Integrated Care Board, which deals with the 20%, which is the clinical need across the city. I've got to say, relationships between local authority and NHS have never been better. And the work that you're seeing here has been long-term work that has been carried out through the integrated care system to actually look at the provision that we've got. We're talking here about Derby, but the care system goes Derby and Derbyshire. So there's a lot of work gone on. The first meeting of the Integrated Care Partnership will be early next week, where it formally becomes an organisation, and that's where the work will continue to be done. We've been working in shadow form for over a year now. So all this has been put into the mix, and I am confident that we'll be able to move forward in collaboration rather than before, where we were in silos and things didn't work. So we are working together. It's proving to be worthwhile moving in that direction, and I'm hoping things will continue.
Thank you. Any questions for Councillor Webb?
So, Councillor Webb, how do you measure the improvement? Or are you waiting that it's going to improve? Because Councillor Martin knows, I work in the community, and I've also been a councillor, and what I hear from my constitution and community, and this taking pressure off A&E, GPs, people keeping fit and healthy. Where is it?
It's available, and you as the councillor should know about our Live Well service, about our community service. As a community volunteer, we are working with Community Action Derby to ensure that the community services are working together with the local authority, together with the NHS, to improve lives. And healthy life expectancy has taken a dip over the last few years, and we need to bring that back up again. So we're doing a lot of work with the community to actually do that. And as a councillor, you should know.
As a
from
community worker, I'm aware of this, and I have invited all these organizations at certain events. Yeah, I didn't see their faces. You know, so that's where you need to get these organizations coming in, taking pressure of primary care and then secondary care. Yeah, so that's where we want not to put pressure on these primary and secondary care. That's where the issue has been arising. And that's where yourself as a cabinet member need to encourage these organizations that we need to be seen more in that community.
That is being done through Community Action Derby. They are the organisation that is representing the community groups across the city and some across the county. So, and we're working with community organisations across city and county to improve lives. If you look at your councillor bulletin, you will be seeing about the Live Well programme. So you can go out to your community and let them know what's going on.
Okay, I'm mindful that I said thank you, Councillor Farmer. I'm mindful that we're really over time, and also this is really just, I think this focus here is about social care and the need for more social, that's the point, is that, so I'm going to let Councillor Froggatt come in.
No, you're right, I'll pass. I can talk to Roy anytime. He's very open, is Roy, can't give up.
Yeah.
So, but Roy, in two sentences, we really must end this item, but what are we doing as a council? I know you talked about to try and recruit more people to social care. I think you mentioned the university and the links with the education. That's excellent, and I know that, I'm sure that does work, but how are we just trying to get more people to take up these social care roles? What are we doing?
We are talking to organisations. There's national press coverage about joining social care, but until we've got a proper career pathway, because it's not just qualified social workers we need, it's people to work in social care.
Yes.
And there is not a properly recognised pathway. And again, written to the Secretary of State about it, because we need that pathway.
All right. Well, that's good. Thank you, Councillor Webb. I think some of us will probably talk to you a bit more outside the meeting, but that has been the longest item we've ever had in this board, and probably any board I've ever sat on. So I'd like to thank everybody for coming along, and for everybody else for your endurance of waiting to do your items. But thank you very much for coming this evening. We may unfortunately have you back to talk again about Florence Nightingale specifically at some point, but thank you for coming tonight, and thank you for coming, Councillor Webb. Right, very quickly we'll move on then. Our next item is services for adults with learning difficulties and autism, and it's Caroline Green, Vicky Taylor, Scott Lunn and Lee Doyle. Hello.
The presentation is slightly on new candidate. So what we thought is we would give you a high level summary, James, and then we would just go straight to any questions.
That's absolutely fine. That's what we would normally do. And normally do that kind of micro level analysis.
So you've got two presentations. So we have the learning disability and autism, and we also have the transition. So you have two sub teams here. We will work together in partnership. I'm Caroline Green. I'm the interim chief exec for Derbyshire House Care. I'm here representing the Mental Health and LD Autism Board, but I also work with the Integrated Care Board as the senior responsible officer for mental health, LD and autism at this point. We have.
Sorry to interrupt, Caroline. So are you kind of merging items 6 and 7 now?
We'll just have the learning disability piece, and then we'll go on to the transition.
Okay, so we're going to transition very quickly, which is kind of useful given that we're running. We'll do that because just
cut to questions.
Just for the streaming, that our second report is on mental health youth aspect sort of going from as people enter adult.
Transition from youth to adult.
Yes.
And what are those things that's particularly?
Yes, that's what we've prepared and we'll have
Thank you.
Okay, so
James, would you like to introduce yourself and then we'll introduce everybody else in stuff?
Sure. So, evening everyone, I'm James Lewis and I'm Head of Joint Strategic Commissioning for Learning Disabilities and Autism. I'm employed by the Integrated Care Board, but I work across health and social care, so I can, at least in part, do my best to represent Derby City Council or Derbyshire County Council, as well as my NHS hat on as well.
If I bring in Vicky, then we'll save you two next, so everyone can remember your names.
Good evening, everyone. Vicky Ashton-Taylor. I'm Director of Strategy, Partnerships and Transformation at Derbyshire Healthcare Foundation Trust.
Do you want to take us through?
Yeah, sure. So the slide deck that we produced this time is meant to update the slide deck we had last year. People remember my charming appearance last year at board. We've included quite a lot of detail in some appendix items, which I'm more than happy to reference to in questions. But just to provide a high-level summary, since we came to you last year, we've kind of developed our vision for what learning disabilities and autism services should be, and we did this in co-production with people with lived experience to help supplement what we've identified the areas that we want to talk to you about today in terms of the priority improvements that we needed to achieve. So the first being addressing our over-reliance on inpatient care for autistic people and people with learning disability. Reducing the waiting times for neurodivergent diagnostic assessments, and I know that Scott's probably going to touch on that as well in his slide deck. Ensuring the quality and sustainability across Derbyshire's health, community and social care services. And I think some of the conversations that you're having with Zara and colleagues earlier are very relevant for our space as well, in terms of workforce, in terms of sustainable community providers. Whilst it's a different area and expertise, we're facing similar challenges. And then achieving good value for money for Joint of Care Derbyshire. And actually the good news on that front is if we achieve those top three things and move care from intensive and restrictive interventions in hospitals into the community, chances are we'll achieve that good value for money. In terms of what we've achieved over the past 12 months, we've created much stronger multi-agency processes and approaches to supporting admission avoidance and expediting inpatient discharges. So we as the NHS and system partners have invested in reach roles, for example, to go into our acute mental health hospitals. We've also prototyped a completely different way of supporting people in the community through a crisis in reach prototype, which effectively had health trained staff on standby 24 hours a day so that they could go into people's usual living arrangements and provide the urgent care that they might need to prevent them from going into hospital. We've continued to excel at key programmes addressing health inequalities, and just to kind of ground that in reality, people with a learning disability are entitled to an annual health check once per year, and they should get a health action plan after that. That is a life-saving intervention, because people with learning disability, unfortunately, in the past have passed away for conditions that probably wouldn't even cross our mind that somebody could pass away from, such as constipation. But that annual health check with a GP can save a person's life. So it's so important that we continue to excel in that area. We've had proposals for significant investments in the neurodivergent diagnostic pathway approved, and I'm sure again that Scott might touch upon this as well. Most of that going into children's services to get diagnosis at the youngest age possible, but also to go to adult services as well to help us address the waiting lists for autism and ADHD diagnostic assessments. And we've better embedded the voices and aspirations of local people into our programme through co-production. I've included a couple of pictures on the slides to help demonstrate some of those events that we had. In terms of future priorities, we're delivering our Joint of Care Derbyshire Recovery Action Plan relating to the availability and quality of local social care provision, particularly residential care, supported living, some of those more intensive 24/7 provisions that people might need. We're working really closely with Derby City Council, Derbyshire County Council on redefining the way that we work with our social care marketplace, and I think it's fair to say better risk sharing with them, particularly where they might be supporting people in the community and feel that they might need more intervention from the public sector. Implementing an all-age neurodivergent diagnostic pathway, including community services which wrap around the assessment process. So later on in the slide, in the appendices, there's a description of how we're using NHS transformation monies. Almost half of that next year we're expecting to go into the community, into the voluntary and community sector, and almost all of that is about wrapping around the diagnostic assessment pathway so that people can get the support they need during, before and after their diagnosis. So the diagnosis is a gateway to support. And then addressing the improvements needed to local specialist inpatient services through immediate and long-term service transformation of our specialist LD and LD hospital at Ash Green, the Ash Green campus site. And what we're hoping will be different in the future is that not only will we achieve our NHS targets around inpatient care, diagnostic assessments and health checks, but also achieve some of those local aspirations that you made reference to in an earlier item, such as less suicidality and fewer deaths by suicide, which is not a national target relating to neurodivergent people and people with learning disability, but one that regularly gets talked about locally. So that's something that we want to address. The creation or the development of neurodivergent inclusive communities, that's a little bit of a misnomer. Actually, what it is about having communities that are friendly to everybody, but there may be specific interventions that communities can do to make people's experience of their lives around others more tolerable. And then more community-based preventative services, as I've kind of mentioned. Yesterday, Derbyshire presented at the NHS Midlands Regional Forum for Innovations in the Adult Diagnostic Pathway, and all of that was focused on, after diagnosis, getting exactly what you need, whether that might be one-to-one support with a therapist, all the way down to information, advice and guidance on how to access better support for housing or how to get support with benefits and things like that. That's our kind of high-level position. Like Carolyn said, we are working together across the system to try to do that. We're trying really hard to embed autistic people and people with learning disability in everything that we do. And there are some really exciting things in the future, but also some really significant challenges. And it's really welcome to come back to Scrutiny and talk about this really important issue. So thank you for inviting us.
Well, thank you, and thank you for the slides, which are quite comprehensive, and thank you for a very quick high-level summary. But that's not, yes, that's just very succinct. Thank you. Any comments, Councillor Lonsdale?
Yeah, my pet topic, isn't it? So you talk about improving diagnosis for adults when they're seeking that. What are you doing about improving the gender disparity between men and women with problems? But all the diagnosis tests are based towards male diagnosis. So
I can certainly start to answer that question. So I think with this is kind of fairly similar to the answer last year, but with some relevant recent context. So we heard from Leicestershire and Rutland yesterday about some targeted work that they've done looking at the diagnostic assessment forms. So for a very brief overview, you ask a series of questions that you assess yourself against to say, yes, I feel like this, or no, I don't feel like this. And the results were quite outstanding, actually. It found that for the mean score for people who didn't actually get an autism diagnosis was higher than those who did get an autism diagnosis in the end. So I think what I'm trying to demonstrate is that this is a very, very complex picture, and even daily we are getting further insights into the particular question. I would say that all of our interventions that we're looking at, whether in children, young people or adult services, need to abide by all the duties we have under the Equalities Act to make sure they are accessible to, in this particular case, gender, but also all the other protected characteristics, gender, sex, and all the other protected characteristics.
I'd just like to say we're trying to develop innovations and technical testings and new tools. Derbyshire is able to secure, working with Newcastle, a review of the diagnostic system. gender and other aspects that we would do to test some of that and add to the evidence base and the NICE guidelines to try and make it more sensitive, make it different. We are still in toddler steps in developing that evidence base, but I hope that next year when James comes again, that he can give you some positive news. Nationally, we've lobbied for it. Nationally, we've asked the national team to review the evidence and also see if we can contribute to that in what we're doing locally. And I do hope that we will get better. Technology is not developed in this area. There are some tests that you can do for different conditions that would give us insights and perhaps would have more sensitivity. We're still a year at least away.
Okay, well, that's at least, that's an honest answer and it's a reasonable one. The other one is, I mean, what are we doing? I mean, obviously you're out in the community and that's great. Is that work partly to dispel stigma around autism, getting diagnosed with?
So our best weapon in achieving this is our Autism Partnership Board, which is actually across Derby and Derbyshire, which is about to come forward with its proposed Derby and Derbyshire all-age autism strategy. So one of the work streams that we're going to be setting up as part of that Autism Partnership Board, in collaboration also with the Derby City Learning Disability and Derbyshire County Learning Disability Partnership Boards, is about developing inclusive communities and what that means for one person with a learning disability living in Derby, living in the High Peak and Blossom. There are some things that we're already planning. So one of the emphasis is going to be on employment and making employment as neurodivergent friendly as possible. That's the exciting piece of work that we're due to launch very soon. I think the other kind of thing that we can do is if we can get people healthy and confident in living in the community, what people will find is that there shouldn't be much stigma, because 2 out of every 100 people is autistic. So actually, there are plenty of people that who will be autistic, potentially undiagnosed, and actually, it's about adapting. I think I coined this phrase last year. It's about adapting what is a neurotypical world to people who are neurodivergent. So there's work ongoing, but actually, if we can do some of the things that we talked about here, then it will give people the confidence to access their community and then themselves be the change agents that you're talking about.
Bill. Okay.
As the Foggett.
Aye. There is a worry that putting people into communities is that they are taken advantage of by certain elements with drugs and alcohol and all that. Are there things in place that will pick this up as soon as possible? Because we see where it goes on for 12 months, 2 years before any action is actually taken to help this person get out the hole that they've been dragged into.
So I think there's two kind of answers to this. I think when we're talking about people who might be in receipt of long-term social care support and things like that, there should be systems around them to protect them from abuse, through their social care commission provider, through whether support that might go into a family home with parent carers and things like that. I think the challenge that we have, potentially particularly with autistic people, is that the vast majority of them don't live in such settings. They live in communities with other people, and you're exactly right. I spoke to a mum yesterday of a young autistic young man who has been taken advantage of in the drugs and alcohol space. So again, I think the previous answer that I just gave about societal understanding and acceptance of people with learning disability and autistic people is going to be probably the thing that transforms this the most. When we're looking at services that protect people like the police as well, there's been investments in those areas and developments in those areas, which I won't speak to in detail because I don't know them, but I know that there's been, through partnership boards and feedback and stuff, there's been areas to look at how do they protect themselves. And also, I don't know if people have my mobile banking app. Santander has a whenever I try to make any transaction, it has a fraud thing come up and say, I'm transferring it to my sister, and she's like, do you know who this person is? There are adapted services for people with a learning disability, for example, that can help them decide, well, actually, is this fraud or not? I don't think we can answer comprehensively that we don't carry any risk relating to that. What we need to do is continue to get better, working alongside groups such as the Derby City Council Safeguarding Adults Board as well, and we are making those connections stronger, but we probably still need to do a little bit more on that.
Thank you.
Questions over here? Maureen, did you want to ask a question?
No, I was indicating autistic.
I thought you were just waving bye-bye.
This is something I don't know anything about, so just a quick answer will do, in a sense, because it's if it's complicated, well, it is complicated, no doubt, but I'm just a bit perturbed by the focus on the people taking their own lives, and just wondered if you could say a little bit more about that in relation to, say, Derby. I know we're increasingly working in terms of Derby and Derbyshire, but this particular board is just responsible for focusing on Derby. And do we have a particular high rate of people taking their own lives in Derby?
Short answer, I don't know.
However, I do.
The report, and I'm just wondering.
So why driving that? Why is it driving that? So we have the National Mental Health, Homicide and Suicide Confidential Inquiry, which maps back as part of the suicide prevention strategy and looks at deaths over time. And it looks back retrospectively over 3 years. And in the research that it has released, it said that there are certain groups which are increasing, and they've seen increases in individuals who have a diagnosis of autism who are neurodivergent. So what James is saying is we're monitoring for this and we are assessing. And in the leader reviews, which are those reviews of anybody with premature death with a learning disability or autism was included a year ago, and they're starting to track and see is that the lack of learning disabilities or autism services that raises to any death, and particularly is looking for a subset. We are very, very attuned in Derby and Derbyshire to look for that. We are not an outlier.
Okay, right, that answers my question, I think. Thank you. Do we have any other comments at the moment on this particular report? No. Well, thank you very much. It seems overall a very positive report. I think, I'm sorry, we might have given it a little bit more time under the circumstances, but it seems to me that there's a lot of positive developments that have happened, but there's still a lot of work to do. So obviously, no doubt, none of us here actually know who will be on the board or what our own positions will be next year. So the board, which may not quite be us, will no doubt look forward to listening to further updates from you. Thank you for that. So shall we move on to the mental health aspect?
Yeah, so if I can please Lee and Scott, would you like to introduce yourself?
Yeah, hi, I'm Lee Doyle, I'm the Managing Director.
Sorry?
Hi, I'm Lee Doyle, I'm the Managing Director, and I have children's and young people underneath my portfolio.
Hi there, I'm Scott Lunn. I'm the General Manager for Children's Services, and that includes children and adolescent mental health services, 0 to 19, public health services, and complex health and community paediatricians. So I'll be here just to feedback specifically on the question that's been asked about transition. So I'll try and stay focused. As you'll see from the report that was presented, there is a number of challenges in the system, which I'm sure the committee's had some reports back in relation to the impact of the pandemic on children's mental health, children's increase in autism, demand for autistic assessments, ADHD, and also when we look at eating disorders as well, which have all had quite a significant impact on service delivery within children's services. And obviously that then, in the natural scheme of things, then it has an impact on transition. So just wanted to sort of give the assurance to the board some of the things that are actually currently taking place in relation to where we're at now. We've been the National Institute of Clinical Excellence with relation to the transition policy, transition guidance, should I say, is currently being reviewed. There's a national transition team that's been developed, and we've been linking in with the national team to look at our pathways locally. We've been working very successfully on a sequin and continue to report to our quality committee on a.
Just Scott, just say what a sequin is.
Oh, sorry, a sequin is a quality initiative that we're active to report back on, and they develop some KPIs in relation to that quality, and then we need to sort of report back on that to our quality committees and back through to the our commissioners. So this, what we've done historically is work on that sequin quite successfully by developing co-produced documentation called a readiness questionnaire, which young people then fill in prior to the transition, say this is what I want from the transition, this is what I would see as a good transition, and then we monitor that through the process. So there's some of the things that we've been working on. We've also started to develop some data systems across our integrated care system, across mental health services, about looking at how many children are transitioning into adult services, how many children then move on into adult services who have been open to children's services, so that we can start to monitor that flow and see if there are things that we can do better within children's to prevent children transitioning into adults. We've also, just on a very practical level, we've got some joint working clinics now working with children's and adult services based in localities, in place areas. So that's geographical areas where we're working very closely between children and adults to look at the needs of children as they're moving onto 18. When it's appropriate, then we can refer through, and we'll offer a transitional pathway for that, which is quite what we're trialling at the moment, is some experts by experience and some peer support to support families, children and parents as they move through that transitional process. And we're sort of maintaining an oversight of this through an integrated care board work stream that is particularly focused on transition again. So it's quite a timely thing to bring here, because I think there's a lot of things happening across our system at the moment, which is trying to ensure that we are maintaining that focus around transition, because it is a particularly vulnerable time. So one of the things that I think the child and adolescent mental health services do is that they don't just discharge when a child gets to 18, and they assess, they look at in terms of what's in the best interest of the child. So we've actually got 250 young people open currently over 17 and a half, and over 100 that are post 18. And they remain in service whilst they're sort of working through the care plan, looking at sort of accessing the child-based therapies and the family work that we're doing to prevent having to move on into an adult service. So we have that flexibility that we work across there. So I think one of the things that we're quite excited about, I think, is one of the opportunities, identified gaps in the report in relation to children with autism and with ADHD and some of the increased demand there. So what we are looking forward to is the Living Well programme, which is attached to the geographical place-based model that I'm sure you've got some awareness of. What that is about how we can engage with communities and increase the support through communities for that population. And actually we've started some of that work now through something called the Community Hub, which we're just going through procurement currently, where we're looking at how we can start to work with the VCSE and engage with the communities to start to build up the network so that children don't have to go straight into a statutory secondary service, but actually can we support them in the community by looking at what's locally available to them. So that's what we're aspiring to achieve.
Well, thank you. Just before everyone else in, just to say, I think that I did talk to Derby City Council's senior mental health person a couple of years ago about this Living Well idea, and we didn't have that in Derby. It was an aspiration that was 2 years ago, or perhaps it may even be 3 now, because like everybody else in the country, I think at some point in the last 4 years, I've lost a year in my mental mapping of time. But I mean, are you now saying that Derby is, we are actually introducing a Living Well sort of concept or service in Derby?
We are at the minute, yes.
Right.
We We've used the national directive and we brought it down to the local area. Our first prototype was in the High Peak. Derby City's been our second area. We started it back in August.
Yes.
We've been prototyping the model, kind of an experiment using the DE24 postcode, obviously. GPs attached to that. We've also been using it against the DE73, which is the Charleston area. We're just about from next week to then start to phase that out, roll it out across all of the areas. So we're just working through that plan at the minute. The idea around Living Well is the preventative model. Giving people the support at the lower end of the scrapes of doing it to difficulties, basically. So when you come into the model, it's a no wrong door, it's one door. The team will then decide what needs are of that person, and I'm not going to call them a patient because it shouldn't really be a stage. And then they'll be then signposted through to the right level of service, whether it's voluntary, whether it's social housing, or whether or not, in fact, they do have a health need and therefore they need to come into Derbyshire Healthcare, be seen by, whether it's the community mental health team. So it's in development. It's had its challenges because it's a model that certainly around the integration, where you might think that bringing people together, working together might be easy. It's kind of working through cultural changes, lots of organisational development behind it. And then the other practical thing, very similar to the conversation with colleagues across there, is workforce. It's looking at the workforce strategy. Because obviously, whilst we've got the investment, it's trying to understand what we need. It also allows us to work, it also allows us to challenge traditional ways of working. So where healthcare can be very medicalised, it's trying to look at that preventative side. And then we will still have consultants, we'll still have nurses, therapists, etc. But it's looking at, what other workforce we could use. So it's certainly happening. There probably will be an opportunity, maybe next time, maybe in maybe 6 to 9 months, is to come back, give you a better picture into how it's working.
What's encouraging is that we've children's services have been part of this, have been part of the co-production of Living Well. So we're very much engaged with that. Our experts by experience, parents are involved, saying this is what we feel we need. And we're engaging with that. And I think there's transition workers that have been identified specifically as part of the Living Well programme. So I think it's quite encouraging, I suppose, that movement forward, especially with the challenges that we've got in the system currently. We do feel as though we are moving in the right direction.
Okay, thank you. Councillor Lonsdale?
Yeah. So, I'm just sort of, there doesn't appear to, from what you were saying, to be any sort of cliff edge that, young people will go to the edge of 18 and then into the cold hard world. That's really good. But obviously they do need to transition. So how is those it wasn't clear to me how those transitions are being managed, if you know what I mean. So is it like a gradual, right, you're in all these services, now I'm going to do one at a time, we will move them across.
That all depends on the level of need and so the person's needs at the time. So we'll, in just relation to mental health, then we'll start the transition process at 17 to 17 and a half. We'll then make contact with the adult team. We'll then engage with them in the planning meeting with the young person and the family and the adult service to say what's the next best step. Are we going to will the offer within adult services meet the needs of the child, or do we need to look at alternative pathways?
Yeah.
So it starts quite early on actually, and then we engage with them and work through over a 6 to an 8 month period of transitioning to adult services. A named worker through that process.
How long? Okay, so it's not quite appropriate if, say, you keep them in for a 6 to 8 month progress. If they're at the end of their 8 month progress through, then it is.
If the required adult mental health services, they stay with us until they're safe in terms of that transition time. Obviously, we work very closely with the local authority because some young people may not need specific mental health services, but they actually need some support and social care. So we'll engage with the social care. We engage very closely with community services as well to offer that ongoing support. There are gaps, and I think that's as I said, some of the living well, we're hoping that it's going to achieve that, and some of the presentation by James as well around the looking at some of the all age neurodiversity pathways is actually going to be really key as well. I think we're looking for all these things to align over the next sort of six months to a year.
Any other questions?
I think I just add to colleagues, we are much better than we've ever been in many years. And if you had been here 6 years ago, you wouldn't have this type of response. So we have grown. It is not perfect, but it is substantially better, is our key message.
And you're working towards that.
Yes.
That's good to hear. I mean, I just would like to just comment, just for the, to make the point really, to note for the board really, it's really turbing. I mean, I think we knew, it was very clear to me during the pandemic, and especially when we were in lockdown, that this was not a good idea for young children and young people. Full stop. It really was, really had a bad impact on them across the board for all sorts of reasons. But you've got the stats here, 400% increase in children and young people with eating disorders during the pandemic, resulting in 100% increase into specialist CYP services. 400% increase in ADHD, ASD referrals. So you've got quite a lot of extra people to help really, and you have got staffing issues, and presumably you've got budget issues. There's always been a budget issue in mental health services for decades. I'm not making a political point on that one, believe me. It's been a long-term underfunded service, hasn't it? So whilst I can see that as a team and as a management function and as with ideas and the Living Well service, which by the way I was very keen on myself, all that's very positive. But in terms of so the direction of travel is positive, the ideas are positive, but in terms of what you can actually deliver a help for people, I imagine it falls well short of what is needed. Is that right?
It does, in fairness, right. Currently it does. What we are working very close with the Integrated Care Board, there's children's now specifically, a children's delivery board within the ICB, and that's got a specific responsibility to have these reports back around some of the challenges in relation to mental health and the statistics that you've seen there. And I think when we start to then look at what we start to do is work with partners across, both with our colleagues at the University Hospital of Derby and Bearsden, we work with the local authority, with education partners, with Derbyshire Community Health Services and Chesterfield Royal, all together to start to try and look at this at a problem as a system rather than individually.
I know, with respect though, can I just pull you up on that slightly? Because what I'm very aware of in time and time again, not just in this relation to this, but in relation to everything, is when the questions are asked, people often say, well, we're working together. Now, I believe that's absolutely the right approach, and we know that we're now have the integrated care systems and everything, etc. But it isn't an answer to the service. It's the fact that people within the service are working together is good, and it's hopefully going to have better outcomes. But it's not actually saying what you're delivering for people who need the service. Do you see what I mean?
No,
because
I do.
I'm not really getting at you over this, by the way. Sorry, I'm unfortunate you've just done this. But in every health-related meeting, every two recently, we keep saying, I ask, well, what are you delivering? And they say, well, we're working together. And do you see the point I'm making? I'm not suggesting that people, I mean, this is what politicians are allegedly supposed to do. It's almost like slipping the question, because working together is important. We all, nobody would disagree with this here, but it's really about what can be delivered. Can you recruit the staff? Are they there? And have you got the funding to deliver the services?
I think it's a really fair sort of comeback on that. I think that we are looking very creatively at different skill mix. So we have engaged with our community partners and a voluntary sector provider who's working in Derbyshire very closely. So we've actually increased over the last 2 or 3 years. We've increased the number of children seen with a mental health diagnosis by 35%. So we've achieved that over the last 3 years as a system. We're continuing to work very closely with those partners to improve upon that, because actually the prevalence rates of mental health, as I've said here, that actually is increasing all the time. So we're constantly, chasing ourselves, if you like. We've done really well to achieve the 35% target. We're now trying to get even higher by working much closer together. So, it's working smarter. So it's also saying, well, actually, rather than my services sort of having to recruit to a specific post, is there a skill that might be elsewhere in the system that we could access that's already there? So how then do we work across the different providers to access that? And so, as an example, in relation to tics and Tourette's as one pathway, we've identified that we've got some specific skills in the north that actually, would be really helpful to access. So we're working very closely with Chesterfield to say, how can we then start to use that resource rather than us having to specifically employ to those skills here. So that's an example of how we can start to work much better as a system clinically.
Just to answer the specific issues, we are increasing the children's young people's workforce. We have been able to recruit. We have been able to retrain. We still have more to train, but we are in much better stead than other areas. We have invested in the programme spend and gone over budget to put extra money in to help some of these services. We will also receive national money for these services. So again, we are doing better. We have money coming. We have plans to be able to train and recruit more people. We are doing exceptionally well. The demand will keep us going for the next 20 years. It is, but we are making substantial headway into it, and we have plans to do better, but we are literally painting the fourth bridge. It is a huge amount of people.
Yeah, and I think that's where, I feel this quite strongly, the point I've just made actually, but I think ironically, particularly in this area, you can see that, the ideal, in the area of mental health generally, but particularly in young people, I know you talk about transitioning and particularly, but, we need to become a society where fewer young people are in the position where they are needing mental health services. I mean, I know that's a huge point, a very general point. I mean, not, but that's what we really need to get to, I believe, overall. And I know that does involve all sorts of changes, but, it does involve working with schools. It does involve, so it is important that everybody works together. But thank you for the answer, because that is the answer I was looking for. But okay. Well, if there are no more questions on this one, no? Right, well, thank you all very much for coming. That is really helpful. I'm sorry to wait further on. Thank you for your reports, and yeah, well, thank you very much. I'm going to have a break. No, I'm
Just want to ask one thing. Yeah.
Oh, we're still doing
He's been waiting there for 6 months.
Yeah, he was doing some work on his laptop. I'll see if I can get his attention now.
Okay, thanks. Right, so we're just going to.
Has he been down there since 6?
Sorry?
Has he been down there since 6?
Yeah, you're right.
Thank you, everyone.
Thank
you.
Cheers.
Thank you. Yeah. We're still streaming, I should say. So this is the final report.
Thank you all.
Thank you.
Oh, yes. Tomorrow he can't make it. He put a replacement.
Oh, okay. Well, he's here now. Oh, a replacement.
Yeah, of course he's gone.
What? Then going to let them know.
If
Unless you'd like to adjourn for a minute.
I'm going to adjourn the meeting for a minute, please. Thank you. Because this is. Okay, so do we adjourn for a moment? So we'll start our Adults and Health Scrutiny Board meeting, and our next presentation is on GP services update from Clive Newman. Clive, could you just remind the board what your role is?
Yes, of course. My name is Clive Newman. I'm the Director of GP Development for Derby and Derbyshire Care Board. So I'm responsible for commissioning general practice across Derby. And the ICB used to be called the CCG. It's the commissioning group. It's not a commissioning group anyway, but it's the successor to the commissioning group. I'm sure you've been here many times. I wasn't proposing to go through my presentation. I think you've all had it and seen it. It is similar to presentations I've given in the past. I'm very happy to answer specific questions about it. I was just going to kind of run through some highlights and just talk to them verbally, and then obviously to go over anything. That's
fine? Yeah.
So key points then. In Derby, there are about 170,000 appointments a month. It's by far, general practice appointments are by far the majority of appointments in the whole system, far outweighing any appointments in the hospitals. So it is a big, it's called primary care. It's because it's often the primary way people access health services. Actually, we're offering in general practice more appointments. It doesn't feel like this, but we're offering more appointments than before the pandemic. The latest information we've got suggests it's about 8% more than it was in 2019. Slightly fewer face-to-face, but still nearly 3/4, 72% are face-to-face. Significantly more than before the pandemic are on the phone. And I'm sure anybody who's contacted their doctors has had that experience. About 40% are on the same day, about 11% more than before the pandemic. And that is partly a function of the fact that we've got more telephone triage, so you're getting a quicker response sometimes, and it's on phone. So people are obviously able to get to you quicker than it would be bringing people in. But, and it's a big but, it's still really variable. And I'm sure you'll have experienced this yourselves. There are practices that where access to patients is actually really good and patients report very favourably. And there are practices where it's really not very good at all, and they have the classic experience of ringing up, not being able to get through, told to ring back. Now that's largely down, and if GP colleagues were here, I'm sure they would say this, that's largely down to demand outstripping capacity. They get more calls and contacts than they have staff to deal with, and they come in a rush. So it tends to be first thing in the morning. And by the time they've used all their appointments up, they just haven't got the capacity to do more. But it's also down to some degree to how they organise themselves. So that could be how they triage demand and shape it, whether they've got a GP sitting or another clinician sitting from taking calls and trying to shape the demand. How they split appointments, so they're seeing on the day stuff, which a lot of us experience, but they also, of course, have significant numbers of appointments, in fact, probably about half their appointments for people with complicated long-term care conditions or mental health needs. And that balance of urgent episodic care and longer-term chronic care management is what they're constantly juggling. It also really depends on how complicated and poorly their patients are. And I know we've had this conversation where there are some areas of Derby where you have amongst the most complicated, I don't mean this in a derogatory at all, but kind of, yes, complex and deprived and patients who tend to be more poorly and more in need of services than in other places. And it also depends how they use tech, so telephony systems, e-consult, triage, all of that. And that, to some degree, depends on their capacity, but it also depends on their attitude and their patients' attitudes towards how they use tech. So that's, I think we've had this conversation, but that's still the case. Previously, when I've come here, we've not had a great deal of information at a practice level. We are now getting more information at a practice level. You may be aware that back in November, there was some national information produced at a practice level called GP appointment data, which is starting to show us information about the amount of appointments, what kind of appointments are offered, and how long people have to wait down to practice. So you can potentially go to that information, have a look at your practice and compare it. It's quite difficult. It's not very user-friendly at the moment. We've got data analysts who are still working through it. So it's not the easiest thing to use, but we're starting to use it to identify practices who seem to have more of an issue. And we've started to work with those individual practices. We've got a list of between 10 and 20 at any one point at any given time, where we're starting to work through, go and visit them, talk to them, see what they're doing, try and understand how that's working, think about what they're doing compared to what other practices are doing to try and help them. And all this, so that's where it is really, here in Derby and across the county, but here in Derby particularly. The other thing I'd say, it's January, we're in the middle of winter. It's been an extremely tough winter. We've had 2 or 3 weeks through December and certainly into mid-January, which have been the most challenging that I've seen in my career, and I'm sure many of other people have seen. And that's been the case for general practice. A lot of respiratory problems, and just a lot of sickness. And my GP colleague routine reporting, 13, 14-hour days, and many more contacts than they would expect to see. So it's difficult right now in such a busy time to get a proper sense of it. And it's obviously difficult right now to go and talk to the practice about that access when every minute I'm talking to them is a minute they're not seeing a patient and they're feeling pressure more than I do. So I'll stop there because that's probably a summary of where we are. But obviously happy to take any questions about that or any questions about the presentation.
Okay, thank you. Well, it was Councillor Foggett first and then Councillor Patterson and Councillor Host. Oh, and then Councillor Khan.
We had earlier from
everyone. Sorry, go on.
Form an orderly queue.
Yeah. We heard earlier from the NHS team that the 111 call demand had gone up 50%.
Gone up 50%.
50%. Yes, there has been flu and God knows what knocking about with all the cold weather and what have you. But I'm hearing from my residents in my ward that GPs are not accessible. Personally, I had a text message telling me that I cannot make any appointments, that I can only ring on that day, and if there is an appointment available, then I could have one. But other than that, I have to keep ringing up. Well, I was having dizzy spells, royal like this one, so I thought, I know, I got live well. And I went down, my blood pressure took right. And that, yeah, and that's what I did. I went in that way because 111 weren't answering. I thought, I've got to get sorted, and so I went to live well. And I had all my little bits done and my pricks, and it was great. So, and then she says, well, we might need to contact your GP. I says, well, good luck with that one. So, and that was 3 weeks ago. I've still heard nothing. I'm not dead yet, so I'm not bothered, you know. But my practice itself has no online yet. You can't even get a repeat prescription. I've even stopped having a repeat prescription. I've come off my medication. I've got all, you know. I've taken my husband's. He takes the same stuff. Because he's classed as vulnerable, he can get appointments. He can get his repeat prescriptions. But if you're basically healthy, they're just ignoring you. And you know what I mean? It's like the vulnerable are taking all the slots up. And just out of context, how's my medical centre coming in Mackworth? Yeah, we'll forget that one.
Can I suggest that actually the medical centre is a point, it's a good point, but I think Councillor Foggett's just set out a series of issues. Can we just see if other people are going to name similar issues so you can kind of answer them all? What, think that's a good idea?
Yeah, I mean,
mind,
my
do you mind,
questions are along the same
Do you mind,
lines.
Diane?
Yeah,
if you do
yeah,
that
I think they all will be.
Because it's obviously, Clive's not going to answer your specific issues because you're not even you're not a doctor.
Not even.
No, that's right. I withdraw that. I withdraw that. I said 3 times already this evening that I'm
You're not a doctor.
clinician. So it was Councillor Patterson.
Thanks. From the figures you gave earlier on, it's clear that phone appointments are boosting the overall percentages. Saying the number of appointments has gone up. You're also saying this is down to phone appointment. Is there any data or evidence yet that has been produced to show that phone appointments are producing just as accurate diagnosis as in-phase appointments? Are people getting the right treatment that they need from phone appointments? It's all well and good saying we're producing more appointments. I know Michaela, we've had residents get in touch who say they can get all they keep getting offered is a phone appointment and they don't want a phone appointment. And I understand it to an extent because when it's to do with your health, you want to have that face-to-face interaction. So yeah, I guess it's just a general sort of point of question around, is data being looked at? Has any been produced in terms of the accuracy of these appointments?
Okay, I'm going to carry on with the questions. I'm going to get, thank you, and let Clive come back at them all because I think they're all interrelated. I mean, I think that's, thank you for raising that. It's such an important point, it really is. Thank you. Councillor Holmes.
I'm just looking at your report, where it says it alludes to the fact that things are improving and everything's better after the pandemic. So why aren't we actually seeing that? Because it is not happening. So where is this report based on? Because I've got to talk specifically about my practice in Mickleover, like Diane hers. So the situation in a practice in Mickleover is that they've still got COVID measures in place. So no more than 5 people are allowed in. And if there's more than 5, you get sent back outside again. That is a big issue in our ward. The second biggest issue is that for some reason, the receptionist seems to be triaging everybody and telling them that they don't need to see a doctor or a nurse, blah, blah, blah. That surely has to be unacceptable. And I have heard that repeatedly, and I have got first-hand experience of it. You're saying that vulnerable people get treated more. They don't in ours because my daughter's type 1 diabetic and she just struggles just the same. I speak to so many residents, they say exactly the same thing. How can we get across to these practices that are just not, and I know that they are very, very low in the table, very low for that reason. But how do we get them to improve? Because it's our biggest complaint as councillors.
Yeah.
And like I say, I've witnessed it firsthand. No way on earth should they still be limiting people having COVID things or letting a receptionist decide on somebody's health, which I can, from a personal view, he did it with my sister. She knew something was wrong, went to Osmaston Road, and she was in hospital for 5 days. If it was left to that receptionist, she had nothing wrong with that. She was exaggerating. What on earth? Why have we got to this point where a receptionist is triaging patients? It's utterly ridiculous. But my question is, how do we make that practice be better? Because I know it's nothing to do with us. We can't physically make them do anything, but who can?
Thank you, Councillor Hull. I can only agree. So it's I'm just going to do the question. Is that all right, Clive?
Yeah, no,
I think
yeah.
be you want to say similar, some points you'll say similar answers. And the Councillor Khan.
Yeah, in my ward, my part of the area, the issues I've had is you ring the GP, you don't get appointments. The secretary of the front says appointments taken, and in the morning, that's people coming to me and telling me this. Sometimes the GP says they're going to ring back, they forget to ring back. And then when they do ring back, they don't take it like that. Some people are working like we are in the meeting. They ring once, police themselves, then they won't return your call. If you don't return the calls, they ring back next morning. So where do we people like us that work? Yeah, so the NIC also should make arrangements for us. And then you ask a question: how many GPs have you got in the surgery? How many patients per day do you see? So so you don't get these answers no more. Yeah, previously your GP was more accountable to the public. Now it's more like you walk in a surgery, it's like rules there. You can't do this, you can't do this, you can't do this. Yeah. So they're still accountable. They're still a fund orders, aren't they? They can't put the public. It looks like they're no longer accountable. You go there and see a GP and you said you want to mention slightly for 1 second, a second in, say no, ring back tomorrow. So, like Councillor Holmes says, we need a solution, because then we talk about walk-in centres and A&E, but it's got to start from primary care.
Thank you. Yeah, Councillor Lonsdale.
So my point's along the same lines, Councillor Carl. Working people are putting off getting their care because they cannot phone at that time in the morning. So like for me, and I know so many other mums who are the same, I'm doing the school run at that time, at the time when the phone's open. By the time I've got the kids sorted and everything done, and I'm got through to after 20, all the appointments. They do get a telephone appointment. It's always, I say to them, look, please don't phone me between X and Y times. I can't pick the phone up. I'm teaching. I can't stop in the middle of a session where I'm teaching children and pick up the phone and talk to the doctor. It's not appropriate. And I can't take a day off, just to talk to the doctor. A whole day of pay lost because I'm a sessional worker. I have 0 hours contract. That's a whole day of pay gone just to talk to the doctor about something that is a niggly thing that, so the people who are on have those issues. So we need to bring back some form of being able to book appointments properly. Even if it is the telephone appointment, they need to say, right, we're going to phone you at this time, or after, but you need to have some sort of, in those surgeries, you need to bring that. So can we please request they have some form of booking, that they don't phone you when you're at work?
Can I thank you, Councillor Lonsdale, and I'm really sad to have to say, Clive, that normally as the chair now, I'd kind of look at the report and try and, balance the views in the room, which have been very anecdotal, largely anecdotal, quite anecdotal, personal experiences, and say, well, look, this is stats and everything. But all I can do as chair now is, I'm sorry, and I don't want to be in this position, is entirely agree with Councillor Holmes that actually, what we're all experiencing on the ground, and I do not challenge at all the veracity of your report, but doesn't seem to be reflected. What's in the report doesn't seem to reflect very much what's on the ground. I mean, I don't want to repeat everybody's points, but a few points I pick up like from Councillor Khan. I'm saying it myself because I agree so strongly that I feel now that it's almost like it's a very unwelcoming service. And there's quite a lot of people who seem to be employed in deflecting you from receiving any care. There's a lot of time spent trying to, and people are actually employed doing this, sort of saying, well, do you need to see a doctor, or is it we can only give you an emergency appointment today, or even an emergency phone call? I mean, you know, what kind of language is that? No GP surgeries should be offering any emergency care in that sense. It's a misrepresentation of language. If it was really emergency, they should be advising you to go to A&E. They're trying to stop you wanting and feeling that you have an entitlement to. In fact, you do not feel you have an entitlement to any GP, any primary care, really. And I'm sorry to be this negative, but it really is bad. I mean, people now, or GPs are now telling people when they need a hospital referral, and this isn't necessarily the subject of your report, advising them to go private. Now, I don't want to enter in a huge political debate around this, around NHS care. I'm not trying to make politics about this, but I really am not. But the fact is that, you know, most people in this country who are in employment, which is still most people, have spent all their lives, I'm going to get upset and try and calm down in a minute because I feel very strongly about this, paying into a system which they have no choice, actually, by the way, to pay into. And there is a great kind of, there's still in this country a collective belief in the and the value of the NHS, as most people who work in it believe in it. It's just, it is so broken. It really does feel quite dangerous. I do know, you know, that people are not getting the help they need in time. Their problems are going to get so bad, they're going to become even, you know, they need more hospital care because they've just not got anything earlier on. And they've paid in, and yet they're being told to the extent that they're able. So some people pay in a lot more than others, but that was the way the system was set up. And they're told that they should go private. Well, why should they pay more? Why should they pay more to have a consultant? You know, I know a lot of people are doing it, and I'm not saying they should never. I'm not saying they shouldn't do it. I'm saying why ought they to? Why are they being obliged to? Why are NHS GP? Surely, if this was a business, this would be seen as a conflict of interest. That actually, you know, you're recruiting. It would look like. I mean, you get sacked in some businesses for advising people to go and use another service and pay somebody out. You know, it's almost like touting for business. I don't actually believe there's anything that sinister or corrupt going on, but actually, it is very, very annoying. And I am going to shut up because I can only agree very strongly with what everyone has said. It doesn't feel safe. It doesn't feel welcoming, and it doesn't feel as if really they're there to give you the service. And you cannot really. You have to work very, very hard. You have to be very determined to get that healthcare that you need. You have to be very, very articulate. You have to be pushy. You have to sometimes be deliberately aggressive, as my husband was. Not aggressive, I take that back, but very, very assertive to say, is it an emergency appointment you need? And saying, well, actually, you know, yes, it is. And then there's a huge element of self-diagnosis going on, because do we need to actually be seen by a GP? Well, sometimes you do, you know, because they literally need to see the condition to know the nature of it. And these can be some cancer-causing conditions, and yet, you know, you're being asked yourself. Now, if you're articulate and intelligent, you can read stuff online. You can think, actually, it's probably this. So, but there are lots of people who can't do that. But none of us should have to do that. So I'm going to stop ranting on myself now. But I just have to say, I'm sorry, but I can only agree with that. I don't really recognise the reality on the ground. Doesn't seem to be reflected in the report.
Thank you, and thank you all for all of that feedback. I think what I've heard is clearly frustration and anger and upset about the service we have in general practice. I think you're concerned about the disconnect between the stats and personal experience, concerned about access, or effectively an inability to access general practice, concerned about how phone appointments work and whether they do work, about how reception teams and other staff's role in triaging and signposting, and a kind of general concern about how we get accountability, the levers we have to change practice, and to make them more responsive. And I completely understand all of that. And I think you're right that I think that the stats are right. That is what we're seeing. But there is also, as we've seen and as I hear and I understand, there is that may be true, but it's also true to say that individuals often struggle to get into practice, to get practice appointments. I would say it's not every practice, and I also have people say my practice works really well, but clearly when it doesn't work and it's your practice, as you say,
sorry to interrupt. I think everybody on this board need the names of those.
That was just going to say practice is really good.
But that, I know, but I think
I'm not criticising my practice. They have such a huge wall to climb themselves. They do a really good job, and they do make me feel cared for and not guilty when I phone up after 6 weeks of having a cough, even though you're supposed to phone after 3, and say, you silly woman, they don't tell me that, but they are very good. And they try their best. They are overwhelmed, and that's my thing with my practice.
And I think if there were GPs here and there is evidence to say that demand for general practice has significantly increased, the number of general practices, the number of GPs has not significantly increased. In fact, it's fairly flat. So you have got a structural issue, and this isn't just in Derby or Derbyshire, this is countrywide, where you have an increase in demand and no increase in GP staff. We have other roles that have come in to try and support that, and that's why the care navigator role, when it's done well, works well, because you don't always need to see a GP, and there is evidence to suggest that actually in some instances you're better off seeing a physio or a paramedic or an AMP or a nurse practitioner. They have a different skill set, they are the right people to see, but I take the point, you need to be triaged there by somebody who knows how to do that triage, and that clearly is the point, that people who are unqualified to do that shouldn't be doing it. So yeah, absolutely. And you're I just going then thinking about our levers. So just on that issue of capacity, the national core contract is about 4 contacts a year. I have practices saying our average, in fact, we're looking at Derbyshire, our average now is 7 contacts per person per year. So patients are using general practice more, which is good. They're contacting general practice more, which is good. But general practice as a system, nationally, is struggling to keep up with that demand. And that's in Derbyshire too. So, and I think a lot of the behaviours you're seeing are from your point, really, which is general practices trying to triage and sort this significant increase in demand and make sure that try their best to make sure that they're seeing the most important things and the right being seeing the right things, and that all of this is in context of all this increased demand. Doesn't make it easier for individual patients, but I hope that goes some way to try and explain it. Some of the things you talked about, the ringing back only once, or as I say, the triaging by untrained and unqualified staff. That isn't good practice, is it? That shouldn't be happening. That doesn't happen in most practices, I would argue. But clearly, in your case, it did. And as I said earlier, we have got information now looking at individual practices, and we are speaking to those individual practices to understand what they're doing and to look at the practices that seem to be doing this well and have good access and good patient survey results, and speaking to those who seem to be struggling and trying to kind of bring those who seem to be struggling up. There isn't an easy answer to this. We've been, as you know, the levers that we have to make change are relatively small, relatively short. A lot of this is about, the workforce, the staff. against demand. And whilst we can support practices to improve how they work, the big gain is in trying to manage that demand and trying to increase the capacity to support that demand that's there.
Well, before I bring Councillor Khan in again, just to go back to some of the points that you've had, thank you. I mean, just for my benefit then, on my particular point, are they permitted to advise people to seek a private referral?
Well,
why isn't that?
Well,
sorry, are they?
So a GP is an advocate for their patient, and they should, and in fact they have to advise that patient in that patient's best interest. The GPs have no conflict of interest. They're not private surgeons. They're working for the NHS. They don't have and won't have conflict of interest in referring outside of the NHS. And if they're referring outside of the NHS, it will be because of their sense of the waiting time, or their view of the waiting time in the NHS and the waiting time in the private sector. They won't be referring. They will be speaking to the patient about their options. They won't be directing. They'll be consulting and advising. But yes, they are often asked, I'm sure, and they are required to kind of give their honest view about a patient's options.
Okay, I can see that's a call, Lucia. And then just before I bring in the councillors, just to go back to Councillor Holmes' question, if I may you up on that. Clearly, I mean, receptionist, being a doctor's receptionist is a very responsible and difficult job, and that's a tough job, and I think we'd all recognise that as well. Not least also because they are becoming, I do believe they're becoming a deflection service. I'm sorry, I have to say. I think it's anyway. I think that when you say not many GP surgeries are using receptionists to triage, I can't see in a way how most of them aren't.
No.
Because if I could explain my question, because if you ring up and they will ask you what the problem is, so that they can, seems to be very widespread. Now, obviously, I mean, in my own experience, basically, I knew I needed to see a doctor. I needed to be seen. I knew it was urgent. And because I've done, because I have a PhD, I go online, I do some research. I mean, it's a ridiculous level of input to come to a conclusion that actually I absolutely have to be seen. So this is what I've done recently. But I had to insist on being seen. In fact, I would not explain my problem to the doctor because I don't want to. It's not her business. And actually, so I was very, very assertive. That's how I got to see the GP, and I was right. I mean, a lot of people are not going to be like this. So you're going to be saying it is like an element of self-diagnosis when you're explaining to them what's wrong. And then there's this thing where they do triage because they'll say, well, that's for a nurse, but they're only then taking it on the word of the person who's at the other end of the phone. This is a million miles from a GP, somebody going in. There's always happened saying, doctor, my back pain's really bad. And they'll say, well, and how is the divorce going? Because that is the reality a lot of the time, isn't it? That actually, sorry, it's not the reality a lot of the time, but what people think is wrong with them is something else. Or they're not. So I just want to go back to Councillor Holmes' point, if I may, that how is that not a point of triage? How?
So I think, sorry, I wasn't very clear. I think there are two ways to. You're absolutely right. Receptionists and other non-clinically trained staff may triage and navigate patients to, hopefully, the right person for them to see. And as you, I'm sure, are aware, GP surgeries are now not just GPs or GPs and nurses. They include a whole range of staff, clinical pharmacists, paramedics now, mental health workers, physiotherapists. So you do need to do that if you're going to operate this system, and it's a very good system, you need a good point at which you're kind of triaging and directing people to the right place. My point was, and I'm not speaking about that practice particularly because I can't speak with authority about it, though I'm not doubting you, that person who is doing that key role has to do it in a way that is trained and supported and checked, and it shouldn't just be somebody guessing. Or so it you know, that is a common, well accepted and well evidence-based model. You don't have to have a doctor triaging everybody. It's okay to have other people. That's how 111 works, for example. They're not doctors on the end of the phone, but it needs support and it needs training. So that was my general point. Yeah, that was my point.
Okay, thank you. Councillor Khan.
Look, like, I'm going to talk about my ward. Every next person I speak to, yeah, they have an issue with GP services, and the same surgeries you're saying, the increase of patients and all that. There's still same number of surgeries where we used to have it before, where there used to be one doctor or two doctors in a surgery, and people didn't have issues. They would walk in. No. Yeah. So now they have other services in there, and I don't feel that these services are either explained properly to the patients, or the patients are left over to the staff at the front, and the only person, when a person is not well, they just want to see the GP. So it's the front staff's responsibility to signpost them in the surgery what are the services there are, so to take pressure off. So every individual I've been talking to recently, GP issues. What are you doing about GP services? We're not getting appointments. We ring in the morning, don't get it. Now this new phone appointments, they ring whenever suits them. And maybe sometimes they forget to ring us.
I mean, I think I'd say your point is right, and it's a point that the last Health Watch report said, which is, you know, there is more work to be done to tell people about the different range of services, and certainly, as we've just said, the point of contact into the practice, be it the receptionist or whoever's doing the triage, needs to be aware of all that and to be able to signpost that. And we need to support people to understand what all those different services do, and that you don't always need to see a GP about everything, because that is, you know, that isn't possible, and it's not actually the best thing often. I would say, and I can understand this issue. People saying my GP surgery is still there. There's still, you know, doctors and nurses and staff in there. Why has the situation got worse? I would again point back, and we've talked about this, and you'll have heard it before. Demand for services has risen. We are an ageing population overall. We're living longer with more complicated conditions. We can brilliantly keep people alive for much longer than we ever used to be able to do. And people have complex long-term conditions, and the doctors, the GPs, are their main point of contact. So we have a relatively small number of people who quite rightly are taking a disproportionate amount of GP focus. And then we have the rest of us who also quite rightly also want to be able to see our GP when we want to see them. And it's that's problematic. And issues like ringback, you're absolutely right. Certainly an ideal would be able to say, I'm going to call you at 10 o'clock or 10:30, or when can you speak, and we'll arrange to meet. And that is what some practices do. And that's also in the Health Watch, people saying, oh, this works really well for me. But it's also true to say that some people, the practices, they can't always say that. And that may be because they're also seeing patients in clinic, or they're on call, or they've got 100 other things to do, and they're trying to fit you in, which is not ideal at all, but is the reality of how general practice sometimes has to work.
Thank you. Councillor Patterson.
Yeah, I just wanted to go back to the point question I raised, around the phone calling, and if there is evidence or statistics yet, or if they are looking into it.
So I think, general practice is a massive profession, and there will be kind of national and international debates, I'm sure, on the outcomes from phone versus the outcome from face to face.
Yes.
So I think that is work that has been done, I'm sure, academically. I haven't seen it, so I can't speak to it. I would say that they do. If you talk to a GP about phone versus face to face, they are like patients. They're not saying, "Oh yeah, we do phone because it's easier." They're saying we do phone because we do phone triage because often it's a really good way to understand quickly what the issue is, and then we can bring the people in that we need to see, and that way we actually can be more efficient because we can physically speak or make contact with more people, and therefore get a better sense of what's going on, and therefore juggle better how we manage our capacity. So they don't use it instead of, they use it as well as, and it allows them to better understand and bring people in. And there's not a practice in the county or city or county that would say, oh no, we don't see people face to face anymore. People, the majority, as I say, 72% of people are seen face to face. And it isn't just, I think there's been a myth that, people that you can't get to see face to face. That's not true. You can, but it is this juggling act, this balancing act they have to do.
I think sorry, just to come back on it, because, and I could be wrong, but it seems like the phone call thing came in over COVID. So it's certainly used quite a lot more.
It certainly
it certainly increased. It seems like it's continued to to be pushed since then. So when you talk about speaking to GPs and doctors, and then we're giving presentations like this, people need to see the data or the evidence to back up what is happening, because nobody's seeing it. We're being told that doctors say it's working for us, it's a good first point of call, but how is anyone else to know that that is actually the case? It's their word of what they're saying works for them, whereas we're often sat hearing from residents that it doesn't work for them. So there's a definite conflict here, and unless the evidence is produced to back it up, and when I go back to the point around COVID, if it does work that well, why weren't we doing it 10 years ago or 5 years ago?
Well, 5 years ago there was a digital first strategy where the idea was that for a long time we've talked about the idea that not everybody needs a face-to-face appointment with their doctor. And for a long time, when I first started my career, that was the talk. Everybody gets channeled to see their GP, whether they've got the smallest of sniffles or the most major of problems. And it's not an efficient use of time. So there does need to be this triage and balance. But I absolutely understand, and I do understand, and a lot of people are quite understandably concerned and saying, I need hands-on, or the doctor needs hands-on time with me. I need to see them face to face. I need to talk. I can't do it over the phone. And that is the balance that GPs have to strike. And they, as I say,
I'm not saying, I'm not trying to make the point that it doesn't work at all. It's a flawed system.
It's just,
we get lots of presentations like we have had tonight, and they're full of statistics and numbers. But for me, this is a glaring point where we're without statistics and numbers. So whilst it might be working, and I'm sure in many instances it does, we've got nothing to back it up
on the kind of evidence base for phone calls versus hand. Yeah, okay. I can look in. I
get it. It's probably a massive undertaking to figure out. Well, following that phone call, was it an accurate diagnosis? Was it done? But
I think the best way to do it would be like looking at academic studies of that evidence base, and I can certainly look into that.
I'm getting, I think that was a comment about time. I'm aware we're running out, so I'm going to have to let Councillor Froggatt in, and then it was Councillor Holmes, wasn't it? Yeah.
Just to pick up on your people can get access to a GP. We don't even have a service in Mackworth anymore. They have now shut the other branch. So people are having to, if they manage to get a face-to-face, are having to go down into town to Charnwood Street, which is 2 bus rides. And also, if they're disabled with electric wheelchair, most taxis don't take them. They won't pick up a motorised wheelchair. So how are they supposed to get access to a GP? You know what I mean? They've got nothing now in Mackworth. Even the Humbleton Drive's gone. They've shut that. We've got nothing. So
we were. Sorry, I'm not changing the clock here, but we'd had reports about a Mackworth Health Centre, haven't we? Years. about 18 months
Yeah,
ago.
it wasn't.
Have you
And that's
Is that still in the
yeah.
pipeline?
The Michael Mapworth plans are still ongoing. They're still in the planning stage, and obviously they're that's separate, but still.
Okay, they're still happening.
Push them along.
So Councillor Holmes then.
Yeah, well, that compounds our problems in Mickleover, as you know, with all the houses. But not answered my question of what do we do about it? What can we tell residents that they can do about it? Because the only thing that we are ever told is your first thing is to put a complaint into the practice, then the practice looks into it. Then if you're still not satisfied, you go somewhere else and you go somewhere else. And then people have forgotten about it by then and it's too late. There should be a body that picks up on these surgeries. Great, these surgeries that are doing well, brilliant, but why are they doing well? Why are some surgeries doing well? We're not in a deprived area, so we haven't got the deprivation issues that the city surgeries have. So why are we doing so badly, and who is going to address it? Who is going to address all of the surgeries that are at the bottom of the pile that get the most negative comments? Who addresses it?
So we, as I say, in my team, we are now looking at this. So we've got the information, better information since November in the last few months, to give us a better understanding, objective understanding, looking at appointment data, looking at the GP survey about which practices seem to struggle. So we've got that. I think I mentioned it, didn't I? We've got a kind of a list of practices who seem to be triggering on a number of indicators. We're now going out to meet with them, to speak to them, to understand what they're doing, to get their perception on it, and also to understand what the practices who seem to be doing really well are, to try and work with them and understand what they're doing that's good, and then try to bring those things together. So there are programs like there's a program called Accelerate, which is a kind of quality improvement program for access that we are supporting our practices who seem to be at the bottom of the, having the most problems to go on. We're working with them on looking at their appointment systems, their telephony, their staffing, their capacity, so that we are looking at it. It's a big job. There's 114 practices. We're a team.
So what do I tell my residents?
So I think
I would say to me,
yes,
you need to do something about it. Why are they still doing COVID measures? Why is the receptionist triaging me and telling me I don't need to see a GP?
So
What's my answer?
I think some of this is yes, obviously people can complain, but you can also approach the practice through the patient participation group, which every practice will have one, PPG, and the idea is that's an opportunity for patients to work with the practice to understand and look at the measures that they're putting in place and to positively influence the practice. That's one option. And I think where there are specific concerns like why have they still got COVID measures in place when nowhere else appears to? That is potentially a conversation with the practice manager. It doesn't need to be a complaint, but just a query to say, can you explain that? We can also, obviously we've got my organisation, the ICB. If there's an issue about something like that, we're trying to understand why that practice is doing that and this practice is doing that, and then we're contactable as well, and you can come to us with those issues. We would say, and you've said already, complaints to the practice should be dealt with the practice, but in practice that's a better, more direct conversation. But those broader issues, as I say, PPG was conversation with the practice manager, trying to understand what's going on. And I know from around the room that people have been doing some of that as well.
Okay, thank you very much. I'm really mindful of time. So very quickly then, Councillor Lonsdale, did you?
I was literally going to ask where Councillor Paterson's statistics. Could you add in if you can, how many phone calls turn into face-to-face?
Okay.
That was all.
Yeah.
Thank you. And very quickly then, please, councillor Khan.
Can it be possible that each surgeries part of the city, like Councillor Patterson mentioned, produce data that how many call outs they do per, and how many patients they see. Yeah. So can you somebody produce that data with each surgeries so that we can go out there
breaking it down
each surgery so that we can go to the community and say, look, these are the surgeries up here. They're saying this is how many call outs we've done.
Appointments.
This is how many appointments and call outs and maybe house visits and all that. So all that, so that we've got a bit of evidence to show.
Home visits. Yeah.
I don't think we can. No, it doesn't exist. No. That's what I heard. It doesn't exist. Home visits is impossible.
No, you do. I think the other thing, because you don't, doesn't mean they don't exist. I think Francis Wood said they do home visits. We also have in Derby, there is the team up team that is, we've invested heavily in or do that. But they are, as I said, there's a lot of complex people, and they may be visiting those multiple times, may not come to you, but they will be going to people. But certainly, as I say, the GP appointment data does have information about appointments. I don't know about home visits, but I can have a look and see how easy it is to show that. It's publicly available, so you can see it.
Could you clarify? So what is it? I was going to ask you, what's the title of this, please?
In November last year.
It's called what, sorry?
GP appointment date. I'll send the link.
And this is this a publicly available website where we can actually look, and all of the members of the committee are going to rush there tomorrow morning saying, where can I move my surgery to?
Yeah, then it all goes down.
Data. What I would say about it, and is that it's the appointment data, as we've already talked about, is it's beta data, so it's not.
Yeah, didn't you say this was difficult to read data?
Well, first of all, it's not very well presented. It's not. It's kind of it's a bit of a dump of data. Yeah. And second, the data that they're using is quite experimental. So it was developed to try and understand how practices, because every practice records their information differently. So it's developed, and now they've tried to standardise it. So it's still not. I would say not. It needs to be taken with a pinch of salt. But yeah, it's there, and I'll send you the.
Thank you. So what I think okay. Well, look, Clive, just anecdotally, what I'd say in response to that is that I think that is really interesting, because I think I myself, others here, are not convinced that this is working. I think we can accept that it's working better somewhere, so it'd be good to know. But on the other hand, I think what everybody just wants is that not for it to be like a league table of GP surgeries and people wasting time producing data all the time, which also, we've got paying people to deflect people from getting any care, then paying people to produce all the statistics, when actually what everybody just wants is a reasonable, not necessarily superb, but a reasonable service of GPs in their locality, so that's what they want. And sadly, it isn't what we've got at the moment. So what I can say is I'm really sorry that you had to wait so long. It's very unusual for us to run on like this. We've never done this before while I've been chair. And so sorry you had to wait so long, and I'm sorry it's such a grilling. But all I can say is that actually this is just, we have to tell you how it is, because it's like we've used some of our own anecdotal experience, because we don't share things that people tell us, but not publicly, but no. We're speaking for the people we represent. That's why we're saying this now tonight in this forum. If we want better care ourselves, I'm sure we could go off and do different things, or we could try, but actually the reason we feel it's so compelling is because this is what everybody's telling us. So thank you for listening, but somewhere it's got to get better.
Thank you, Clara.
Thank you. Right, so thank you for that. So very quickly then, are we doing the late item now? Or? We
can do the work programme.
Okay, on the work programme, do we need to comment, make any comments on that? Does anybody want to add anything to our next meeting? Can you tell us what we've got lined up for the next
You've
meeting?
got the topic review, COVID-19 update on dentistry, voluntary sector contribution to health inequalities, update on the community strategic approach to engagement, an update on the urgent treatment centre review and maternity services. So we've got
And we'll probably be here till 12 o'clock if we. So
When is our next meeting?
and that one's on the 18th of April.
We'll get another one.
so basically, yeah, that's what we have. I'd suggest we don't add to that.
No.
Okay.
Don't have emotive topics.
The topic review, I will just say that the current one, just to say that we had a meeting, another further meeting with Robin Jewis to talk about obesity. It's very interesting. We've set it, there isn't time to go into detail, but what I would say is we are planning to have a meeting with Paul Clark, the head of planning. That's mainly in relation to planning permission for fast food outlets, and also a meeting to talk to Move More Derby. Okay. And then any questions or points on that or the work programme? Okay. And then our late item is the cabinet member response to the care homes topic review that we did. That has gone to cabinet, and I've spoken to it there. It's very late. Would anybody like to make any comments on that cabinet member responses? No. I'm inclined to say that we just know as the cabinet member is still here. I just take 30 seconds.
Give me some plugging his
I don't want to, there isn't time to probably just note this, Roy, rather than go through it. But one thing I would say, I think the responses were fair, but I think on a few areas, you know, when we're talking so much about we're all working in an integrated way and we're all working together, I think that there were a few areas of recommendations that we made, particularly say in relation to care homes and whether they look at people's personal lives as well as their clinical needs. And the responses said, well, that's the responsibility of the care homes as monitored by the Care Quality Commission. Well, what I would ask, and that's all true, we know technically, but what I would ask is that given that we're all working together, as we're often told, I think the council now has this ability to, not least because it pays for a lot of these services, to talk to these organisations, to make the case for some of these things, even if they don't have the responsibility. So that was my main reflection.
We have regular meetings with the care homes and they bring issues, we bring issues, but at the end of the day, they are independent organisations.
Indeed.
And although we pay fees, we have no control over the management. It's the CQC that's responsible.
And I think absolutely. And I think that given that it was, I just think that it was a very, we worked at length on that topic review, and given that it was unanimously supported, I think it would be something that would be helpful if the cabinet member, which will not be yourself, Roy, because you're choosing to stand down, gave some more thought to and was more of an advocate of in these shared forums. That's my main point. But thank you. I'm going to end the meeting there. Thank you everybody for coming along, and thank you